Good afternoon, everyone. It gives me immense pleasure to invite you all to this online CME on emerging techniques in management of poor ovarian responders. This is a biggest dilemma which all of us, the ART clinicians, face. And today we have, galaxy of great ART specialists who are going to share their experiences and give us the evidence also on what is new in the management of different Poseidon groups. So this CME, we are honored to do it with we are the SIG poor ovarian responders from the IFS. Dr. Kocher being the mentor, Dr. Firuza Parikh, the convener, and I, Dr. Neeti Tiwari, and Dr. Nymphia Valecha are the co-conveners of the SIG. Dr. Firuza Parikh was supposed to join the meeting, but because of some personal, commitment, she could not. But we are honored to have Dr. Meenu Vash and Dr. Suveen with us, Dr. Ritu Prasad and Dr. Suveen with us. And I would like to invite Dr. Ritu Prasad to give a welcome address to all the participants.
Thanks, Dr. Neeti. Warm greetings of the day. It's an immense pleasure to be here this day. I, Dr. Ritu Prasad, Chapter Secretary, IFS Uttarakhand, welcome you all on this online CME, this on emerging trends in management of poor ovarian reserve. Firstly, I would like to convey my thanks to our Honorable President, IFS, Dr. K.D. Nair sir, our distinguished Secretary General, ma'am, Dr. Surveen Guman, ma'am. Cordial invite to whole team of Special Interest Group Poor Ovarian Reserve, who are so dynamically active. I've seen in rest of the chapters also. And because of them, only this meeting today is being possible. Mentor, respected Dr. M.K. Kocher, ma'am, and this convener, glorious Dr. Firoza Parikh, ma'am, although ma'am is not, would be present today, and our two noted celebrated co-conveners and smart also, Dr. Neeti Tiwari and Dr. Nymphia Valecha. Warm welcome to both of them. Our eminent chairpersons, Dr. Professor Jaya Chaturvedi, ma'am, and Professor Ruchira Nautiyal. Our guests are renowned and well-known guest speaker, Dr. Shweta Mittal, ma'am, and whole team of our distinguished and knowledgeable and luminous panelists, Dr. Leena Wadhwa, Dr. Meenu Vash, Dr. Aditi and Dr. Akriti Gupta, Dr. Latika, and Dr. Shalini Chawla. As we all know, that poor ovarian reserve indicates a reduction in quantity and quality of ovarian follicular pool in the women reproductive age group and is an important cause of infertility in many couples. Existence of POR has been unmasked due to increasing acceptance of IVF and ICSI as a modality of treatment. It is believed that approximately 10% of the women undergo IVF will show poor ovarian response to the gonadotropin stimulation. So, early detection and active management is essential to minimize the need for egg donation in this cases, in this type of commissioning couple. As we will discuss that laws since the pass of ART bill and formation of National ART Registry and Surrogacy Board have become more strenuous and strict. So hope through this webinar, we would be able to give more insight into this important topic and benefits our colleague participants also. Thank you.
Thank you so much, Dr. Ritu Prasad, for your welcome address. Now I invite Dr. Surveen Guman, who's the Secretary General, the dynamic general behind all of us. So, Dr. Surveen, ma'am, please address the audience.
Thank you, Neeti. I would like to congratulate the Poor Ovarian Reserve SIG. They've been very active, Neeti, Nymphia both, and of course under the leadership of the convener and the mentor, Dr. Kocher. It is great to have the Uttarakhand chapter, Ritu, with us today. The topic is extremely relevant because this is what we all go through, either an unexpected poor responder or an expected poor responder. And we are left in a dilemma. I think the Poor Ovarian Reserve SIG is doing a great job connecting with the chapters and passing the message on for these CMEs. It's these webinars. So without taking too much of time, I think we go across and start the CME. Neeti?
Now, I would like to invite our the chairpersons of the first session. So, moving on to the first session, the chairpersons. Just Himanshu, are you able to get in Dr. Kocher because she's trying? Dr. Kocher is trying. Himanshu, can you just let her in, help her in some way? I think sometimes this technology becomes difficult for.
No, ma'am, not able to see her.
Is she trying to get inside?
No, ma'am, not in the waiting room.
And she's able to, but okay. Anyway, so we invite the respected chairpersons of this first session, Professor Jaya Chaturvedi, who is the Dean Academics, HOD, Gynae and Professor Yal, who is the head of the department, Obs and Gynae, Himalayan Institute of Medical Sciences. We are honored to have these luminaries from the Uttarakhand, from the academic scene, here chair the first session. So if they are there, Dr. Jaya and Dr. Ruchira, Dr. Ritu, are they there?
No, no, I was just looking after them. Actually, how?
Hello?
Hello. I think they have not joined yet.
So should we proceed? They can join in middle if.
Yeah. When they'll join, I will
start.
them. No, they haven't joined yet.
They haven't joined yet.
I've dropped a message to them.
We can start.
We can start with the academic program.
They can join in.
It's an honor to introduce Professor Surveen Guman Sidhu, who is Senior Director and Head IVF and Reproductive Medicine Center, Max Group of Multi-Speciality Hospitals. And we know of her, besides her, what she has achieved in professionally, she is academically very enlightened, and she keeps writing chapters, books, and has been giving we are very fond of listening to her in all her academic ventures. So over to Dr. Surveen.
Thank you, Neeti, for the kind introduction.
Ma'am, you can start sharing now.
Yeah, I'm doing. You can see the screen.
Yes, sir. Yes, sir.
Greetings from IFS, and to everybody who's on board, let me make an announcement. 8th to the 10th of December, we have our annual conference in Delhi. So we hope to see all of you there. It's a good notice of 9 months. Okay, so coming on to, I'm going to be speaking on unexpected poor responder, what's new. This is one of the most difficult things to deal with, because your patient is fine and suddenly there are no eggs when you do a retrieval, or there are very few eggs. So there are two terminologies which we need to understand: poor responder versus hyper responder. So a poor responder is somebody who has less eggs and will give you less antral follicles and will give you less eggs. A hyper responder is somebody who had plenty of eggs and gave you very little eggs. So there could be an appropriate response where there are less eggs, but she gave enough, 80% out of those less ones. So once we understand these terminologies, we understand the difference between all these. The objective of ovarian stimulation is securing in the shortest time to live birth while avoiding negative consequences for the mother and the newborn. So what is Poseidon? It is the patient-oriented strategies encompassing individualized oocyte number. So they have totally changed the concept of poor response by introducing this to clinically, deal with patients, help clinicians to explore the possibility of using individualized strategies to obtain that number of oocytes by which you can have one euploid embryo, because one euploid embryo would give you a higher chance of pregnancy for transfer in low prognosis women. So basically, you might be having less eggs, but you need one euploid embryo to actually give her a good chance of pregnancy, although not necessary that she gets pregnant with the one euploid embryo. So if you look at it, the Poseidon group is divided into two sections. Group 1 and Group 2 are women who are perfectly normal, under 35 and over 35 with a good AFC, AMH, but they responded very poorly in their stimulation. So they are the unexpected low ovarian response. And these are the women I'm going to talk about today. Group 3 and 4 are the expected low responders. So where the AMH is low and you are expecting a low response. So patients who fit into an unexpected poor responder, that is Poseidon 1 and 2, should be assessed for two indices, FORT and FOI. Now, FORT is follicle output rate, that is the total follicle output rate, means that it measures the consistency between what you're seeing, the antral pool of follicles at the beginning of ovarian stimulation and the number of pre-ovulatory follicles at the end of stimulation. So how many have actually grown from them? And follicle to oocyte index means the number of follicles and the number of oocytes retrieved. So what is a hyperresponder? That in a numerical term, you could say a FORT less than 50 and a FOI less than 50 would suggest a poor response. Now, what are the causes of a low FOI? That you had enough antral follicles, but the oocytes you retrieved were very less. It could be you didn't stimulate well and you gave too low a gonadotropin dose. It could be a genetic or an environmental factor. We'll come to that in detail. It could be asynchronous follicular development, which we are seeing all the time, that some follicles became large, some were small. So when you triggered, only a few were mature, the others were like in the middle somewhere. And it could be technical issues involving triggering. The trigger was not given properly, not timed properly, or the oocyte pickup, there was something going wrong with the suction pump or your technique. So a single extra oocyte may increase the chances of pregnancy considerably. Number of eggs in IVF is a robust surrogator. So it really actually, the number really makes a difference to your success rate. And the number of eggs to maximize a live birth has been identified as 15. So when patients come to you for egg freezing, 15 is the number you need to give to them to say that, yes, you will have optimal outcomes with your egg freezing. In 2016, Poseidon Group introduced a new marker of ART, namely the ability to retrieve the number of oocytes required for one euploid embryo transfer. And this marker represents a logical endpoint to guide clinicians to develop an individualized treatment. That means that, yes, if there are less eggs, maybe you could do multiple retrievals. If there are more eggs, maybe one retrieval would be fine. Maybe less eggs, you use higher doses. Less follicles, you use higher doses so that all the follicles come up. What is a euploid embryo important across all ages? Why is it important? The availability of a euploid embryo for transfer may change the fate of low prognosis patients, as 50 to 60 euploid blastocysts implant across all age categories. Now, this is one thing you have to understand, that whether it is a woman of 25 or 35 or 40, if she has a euploid blastocyst, the pregnancy rate will be 50 to 60%. And hence, now our clinical medicine is targeted towards getting that one euploid blastocyst. How does the number of oocytes become important? Higher the number retrieved, the probability of obtaining an embryo which is euploid would be higher, because there's more chance. In group 1 and 2, the optimal number of oocytes may not be feasible in patients in group 1 and 2. In group 2, it is further worsened by age. So these are low prognosis patients. But group 1 and 2 benefit from a pharmacological intervention. So group 3 and 4, the expected poor responders, where everything is low, may not be treatable. But group 1 and 2, there is evidence that you can change the outcome. So how do we practically implement it? There is an ART calculator which has come into being, and it has developed to assist the clinicians to counsel and plan their treatment. Now, it is important to assess the aneuploidy oocyte yield to prognosticate. So, a single euploid blastocyst has a 60% chance. That is one thing you have to counsel the patient. The second thing you have to tell her is that what is your chance of getting a euploid blastocyst? The ability to retrieve the number of oocytes needed to obtain at least one euploid embryo transfer was proposed by Poseidon as a new measure of success in ART, and it is dependent on age, expected aneuploidy rate, fertilization rate, blastocyst formation rate, and total number of oocytes. And hence, the ART calculator takes into account all these to predict a oocyte yield needed to develop this should be euploid blastocyst. Young women require at least 4 to 7 oocytes for this, and older women would require about 12 to 15 oocytes for this, because older women would have more aneuploidy and less euploid. Now, the first step, this is the most important parameters to predict the chance to conceive after IVF, are two. One, number of oocytes retrieved, and the second is the woman's age. So if she's a poor prognosis patient, then these two parameters become the most important. An efficient predictor of ovarian response is therefore pivotal in defining a tailored controlled ovarian stimulation for each of these patients. And it should be based on AFC, AMH, and namely the most widely used biomarkers at present. So, poor response. Ovarian hyperresponsiveness to gonadotropin stimulation remains an undervalued issue in ART, both in research and in daily clinical practice. Not surprisingly, the prevalence of this condition is still unclear. So what is the incidence? What is the prevalence? We still don't know. But we do know that in certain papers, 10% of women defined as normal responders required a more than normal total dose of gonadotropins. That means that, yes, they were poor responders because they had to be pushed. And in 2018, this article was published where they found that approximately 45% of patients aged 18 to 40 who underwent ovarian stimulation used doses of 150 to 225, but they retrieved oocytes of less than 10 in number. So they did respond poorly to optimum doses. Amongst the Asian population, it was this was a paper from China, and they found a 21% incidence of unexpected poor response, which is quite high. So coming on to the genetic and environmental factors, we've talked about doses, we've talked about asynchronous growth. So hyper-responders, so they require people who have a genetic LH polymorphism or a FSH receptor variant. These are the two categories which are going to require a higher dose, and hence they can be subjected to a pharmacogenetic approach. What is a pharmacogenetic approach? We know that these patients, if they are homozygous, they require a very high dose of FSH, or total gonadotropin dose is much higher than heterozygous carriers, and those who are normal have even a lesser dose requirement. So we would, if they are tested, we would know that yes, these are the patients we need to start with a higher dose. So that is the pharmacogenomic approach. So Poseidon group 1 and 2, an option would be for clinicians to assess most common polymorphism. Now, if you have an unexpected poor responder, you can put forward to the patient that it is possible that if we haven't found any other cause, the genetic cause is there, and whether she wants to get thus tested. Thus, patients could be identified beforehand and treated according to this approach by giving higher doses rather than just a trial and error of starting with 225, not responding 4 days, then increasing. Genetic differences among individuals might affect drug response, thus ultimately leading to the development of personalized drug therapies to compensate. Based on this data, 5 main strategies have been considered for the poor responder, the unexpected poor responder. One is use of recombinant instead of urinary. They have found better results. FSH dose increase, that you start with a higher dose and you can increase further. A recombinant LH supplementation, which I'll be talking about. Adjuvants like DHEA supplementation and dual stimulation, the combination of follicular and luteal stimulation in the same ovarian cycle to increase numbers. Use of recombinant FSH. Now, recombinant FSH, we all know, is more potent gonadotropin formulation than a urinary. And it has been shown, especially in poor responders, that you do retrieve higher number of oocytes compared to a urinary, because the urinary has a lot of variation in it. It could be, you could be giving 300, but it may be 150. These findings seem to relate to a higher biopotency of recombinant formulations. So, does increasing the FSH dose help in these FSH receptor polymorphisms? Yes. If you see this group 1 and group 2 both have the FSH receptor polymorphism, and one is being given a higher dose, and you see that the peak estradiol level is much more for the group which was given a higher dose, showing that yes, more oocytes have been stimulated. And if you look at the group which does not have this polymorphism, then a lower dose is working well enough. How much should be the dose increase in these women? Evaluated the effect of FSH dose adjustment in women with history of suboptimal. This was a paper in 2018. 160 women under 40 years with a poor ovarian response earlier. The dose increment of recombinant FSH in subsequent cycles carried out 4 months later, and they found that a higher number of oocytes were retrieved with higher doses, 9 versus 6, which is statistically significant, and a higher good quality embryo, 4 versus 3, again statistically significant. So they found that 50 IU increase of recombinant dose would lead to 1 more oocyte, which is actually very significant. Now, coming to the role of LH in ovarian stimulation. We all know that once the follicle reaches 10 mm, it has acquired LH receptors and it becomes sensitive to LH, and LH guides the stimulation further. Optimal follicular growth can be obtained with the right amount of LH. Now, LH has a threshold concept, that means it should be above a certain limit, but at the same time, it has a ceiling concept that when LH is very high, the follicles do not grow. So there is a thin line between these two. There is a LH therapeutic window between the LH threshold and the LH seal, and we need to identify that. So how is LH supplementation and age related? Now, most women will have sufficient amount of LH and they do not require LH supplementation. But those women who have a deeply suppressed endogenous LH, either we are giving an agonist or an antagonist, maybe we start the antagonist on day 5 and that's the time we need to give LH, or they are hypogonadotropic hypogonadism. Again, they'll have a low LH. So 20 to 30% of these women have less sensitive ovaries. Some of these, 20 to 30% of all women will have less sensitive ovaries. I'm not talking about those who have been endogenously suppressed. And a part of these women is older patients and the poor and slow hyper responders, which you're seeing, where you are stimulating and suddenly at 12 mm, they just don't move. They'll go to 12.5 after 2 days, maybe 13 after 2 days, and they're not moving. That's the time where maybe an LH supplementation would help. So what happens in older women? The exogenous LH required, there is a decrease in androgen production by 50%. We all know that it starts at the age of 30. But there are also a reduced number of functional LH receptors which occur as the woman goes older. So the exogenous LH required may be much more, because it is required for androgen aromatization into estrogen, thus restoring the follicular milieu, and a direct impact on the follicular growth through LH receptors and the maturation. So the recovery and quality of the oocytes then becomes LH dependent. Why is there hypo response with normal ovarian reserve? And how does LH benefit? So the mechanism by which recombinant LH exerts its beneficial effect is not fully understood. Although it was advocated that excessive suppression of endogenous LH after down regulation may create the need for LH, they found no significant association between serum LH levels and ovarian stimulation and the response to recombinant LH supplementation. So you cannot write a LH and then accordingly monitor your LH doses. They say there's not much correlation. Genetically determined characteristics of LH itself or its receptors. So there is a carrier of LH beta chain variant And this has an ovarian resistance to exogenous gonadotropins and requires a higher dose of recombinant FSH during ovarian stimulation as an immunologically anomalous form of LH caused by 2-point mutation beta subunit gene. The LH variant has elevated bioactivity in vitro, but significantly shorter 5 to 9 minute half-life in circulation. And this variant is quite common with a carrier frequency of 0 to 50% in ethnic groups. And in Italy, it has ranged from 12 to 13%. This is a paper from Italy. Another polymorphism that might be implicated is in impaired ovarian response is the LH hormone and HCG receptor. So there is one which is a LH beta chain variant, and there is one which is a receptor polymorphism. Which group of POR benefit from LH supplementation? Now, it is seen that basically Poseidon group 2, where they are older women, they are the ones who are going to actually benefit, but even group 1 does benefit. So let's see this paper in 2012 from about older women. So women under 36 and women over 36. This was a systemic review and meta-analysis conducted by Bosch. Age-related effect of LH supplementation in controlled ovarian stimulation. And what they found was that in under 36, LH actually did not have much of a effect. But in over 36, they found that it was 1.5 times more effective. So should you increase FSH or should you add LH in a hyperresponder? So you're stimulating and she's not responding. Do you need to increase the FSH dose or do you need to add LH? Now, this was a paper which showed that one group, they had added LH, and in the other group, they made the FSH 450. And the oocytes retrieved were much more in the group in which they added LH with a p-value of 0.01. And the implantation rate and pregnancy rate were higher in this particular group. So this was a meta-analysis of 2014. So in 2014, this was a meta-analysis to assess the outcome of recombinant FSH plus recombinant LH. Significantly more oocytes were retrieved and a higher clinical pregnancy rate was seen in recombinant LH. So who will benefit? Well, they found that both group 1 and group 2 benefit. Age itself is also one of the very important things in which LH would be helpful. So now coming on to a randomized control trial of
got muted accidentally. Dr. Surveen, you're muted just now, just a few seconds back.
Is it okay?
Muted,
Yeah.
ma'am.
Yeah, now we can hear.
Yeah, I was just talking on the side, maybe somebody muted me. So now to see what is the good dose, 75, 150. They found that the oocytes retrieved were more when you used a 150 dose. Percentage of mature oocytes was also much more. So maybe the dose of 150 is better. How much to be added? Well, in agonist cycle, definitely 150. In antagonist, you can do a 75. Agonist, they're deeply suppressed. And when should it be added? Agonist cycle, you should actually start the therapy with LH because they are suppressed. In an antagonist, you can start, when you start the antag, you can start it at that time. When in the first cycle, if you're just doing a first cycle, then the stagnation, when you observe a stagnation, even if she is not been a poor responder, it's the first cycle, add LH. So the moment you see that your follicles are growing very minimally, this patient needs LH. And you add LH and you see how well the follicles grow. Now, another thing, whether recombinant or HMG, well, there are studies which show equal efficacy. There are studies which say that recombinant is definitely better. So I would not comment on that. To conclude, 2018 systemic review of further meta-analysis evaluating the role of recombinant LH in ART concluded that adding recombinant to the stimulation protocol could be beneficial in two subgroups of patients, namely Women with adequate pre-stimulation ovarian reserve parameters, that is the unexpected hyperresponse, and those 36 to 39 years of age. Patients classified as Poseidon 1 and 2 will fit into the former subgroup. It seems to consider sound adding recombinant LH to ovarian stimulation. For them, 75 to 150 can be started in mid-follicular phase in an attempt to rescue the ongoing cycle, or on stimulation day 1 on subsequent cycles. Coming on to androgens and DHEAs, we all know that androgens have been important, especially since these are the androgens are converted to estradiol, and it is seen that the antral follicles are sensitive at this stage to DHEA. So decreased ovarian reserve appears to be deficient in androgens, and it may be befitting to give androgen supplementation. It is seen that androgens decrease with age, and hence the poor ovarian reserve sets in. But these are older papers of 2013. So here, the Gleicher had come up with the DHEA being very good for poor ovarian reserve. And he found that more embryos, more M2s, more oocytes were there after the patient was given DHEAs. Similarly, cancel cycles were less, top quality oocytes were more, fertilization rate was more. Increase in oocytes and embryo yield was much more. And if you see number of oocytes is more, fertilized oocytes is more, embryo grades are better, and normal day 3 embryos are more. All clinically significant. They also found that it increases the AMH and improves the clinical pregnancy rate and the live birth rate through all these effects. The clinical pregnancy rate is also increased because the aneuploidy rate was seen in these papers to be less. And under 35, the effect of this is much less, but over 35, they found a huge decrease in aneuploidy rate. And that is because women over 40 will have more aneuploidy. So when you give a drug, the effect seen would be much more. So reducing aneuploidy is decreased miscarriage rate in these women. And when was the effect seen? Basically, it starts at 2 months, both for premature ovarian aging as well as diminished ovarian reserve. For premature ovarian aging, maximum effect was seen at 10 months of supplementation, whereas for diminished ovarian reserve, it was seen at about 6 months. So maximum benefits are again in the unexpected poor responder, group 1 and group 2. The testosterone gel from day 21, it has been found to improve results, but there is conflicting evidence of DHEA and testosterone. A Cochrane review of 2015 found that the DHEA 12% chance of live birth increased, testosterone 8% increased to 10 to 32%. However, they said there is insufficient evidence to draw any conclusion. A meta-analysis of 2016 again said DHEA has no effect, but testosterone supplementation may increase. Very recent studies, and there's a Cochrane review of, I think, 2020 or 2021, which actually says that there is not much effect. So androgens in poor responders, it's an unexpected poor responder. They found that this meta-analysis had 2 randomized controlled trials, and they found a higher live birth rate and lower miscarriage rate and a higher ongoing pregnancy rate. But again, data is very, very conflicting, and recent data has probably not supported androgen so much. Growth hormone. Now, growth hormone is produced by the pituitary, and it is found in the receptors of the granulosa cells, theca cells, and luteal cells. So obviously there is a role in steroidogenesis and gametogenesis. It helps in ovarian stimulation. How? It helps in recruitment of primordial follicles into the growing pool, protects the antral follicles from undergoing atresia, increases the sensitivity of the ovaries to the gonadotropin stimulation. Growth hormone, 2010 Cochrane review found a live birth with an odds ratio of 5.3. There's an increase, and similarly with pregnancy rate in poor responders. And they found that the serum E2 levels increased, the number of M2s increased, 2PN increased, and number of embryos increased. All of them on forest plot showed an increase. Similarly, the implantation rate and the clinical pregnancy rate also increased. A higher concentration of growth hormone in follicular fluid is related to a good embryo morphology. So there was a test done by Mendoza where he evaluated the growth hormone concentrations. And oocytes harvested from follicles with a normal antral follicular growth hormone concentration were more fertile. Hence, it was concluded that growth hormone enhances the oocyte quality also. Usually given 4 to 12 units. I give it daily from day 4 onwards. I give 4 units. If she's obese, I give 8 units. And I'm going to talk very little on dual stim because Shweta is going to be covering this. So when there's a poor responder, basically what do you need? You need more eggs. How do you get more eggs? You might stimulate with higher doses of FSH, but still it's not going to give you more than what the antral follicle count is. And if the antral follicle count is less, then that is what you're going to get. The only way to increase the number of eggs is to do 2 stimulations back to back. Why do we say back to back? Because we often find that patients drop out later. And what they found was that the results are pretty similar of the number of oocytes retrieved, quality of embryos, the maturation rate, cleavage rate. Everything is pretty similar. Shweta is going to talk more in detail on this. Diet and unexpected poor responder. I found this very recent paper that elevated dietary glycemic load as well as carbohydrate intake and fiber intake is slightly associated with unexpected poor response. So this is the algorithm of treating a poor responder. So you can do a pre-treatment protocol, consider the ART calculator, consider androgens in selected patients, and go in for either a conventional or a higher dose. So you will do a recombinant FSH is better if she can afford it, and start with a higher dose. Maximum daily dose can go up to 300 in a Poseidon 1 where she is young. And you can consider adding LH in a 2:1 ratio of recombinant and LH in the stimulation if a woman is not responding and she has consumed a higher dose or there is a history of follicular stagnation. In Poseidon 2, recombinant FSH at 300, you can consider duostim because these are older women, they're going to have more aneuploidy, you need more eggs for hunting out a euploid embryo, and a recombinant FSH of 150 from stimulation day 1 would be a better idea, both in agonist and antagonist. Consider antagonist regime, a GnRH agonist trigger an elective oocyte freezing, embryo freezing in case of AMH being higher, which we usually don't find. Consider pre-implantation genetic testing in Poseidon group 2 more because of the age, and consider a single blastocyst embryo transfer. To conclude, what's new in an unexpected poor responder? The management and treatment of patients with unexpected poor ovarian response is still a controversial issue in IVF. Increasing evidences demonstrate that the number of oocytes retrieved after controlled stimulation greatly influence the clinical outcome. So number becomes very, very important for a cumulative live birth. And we should hence optimize this number according to the ovarian reserve of the patient. Pharmacogenetics plays an important role, and hence your dose should be decided according to that. However, gonadotropins cannot compensate the absence of follicles. So if your follicles are less, antral follicles are less, you do need to go in for a duostim with multiple follicular waves. Rejuvenative therapies, mitochondrial transfer, stem cell, PRP, well, there is no evidence of in unexpected poor responders. There are no randomized control trials. Of course, there are studies which are coming in. So can we help with ovarian rejuvenation stem cells? Well, experimental, but some studies are showing results to get the ovary back on the red carpet. Medicine is undergoing an important transformation from a reactive to a preventive approach. The future will focus on an integrated diagnosis, treatment, and prevention of disease. So our prevention of disease here could be, going into genetics, finding out, and then accordingly treating the patient. The general state of health in reproductive environment is gaining increasing in attention, and we must be dealing both with the general health, and by general health, I mean that is she moving towards menopause at an early age, and reproductive health and challenges The challenge is constant innovation and research. And in that constant innovation and research, one of the secrets of life is to make stepping stones out of stumbling blocks. So if you have a poor responder who is there in your clinical practice, consider her not a stumbling block, consider her a stepping stone. Because the illiterate of 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And that is what we need to do with a poor responder. Thank you.
Thank you so much, ma'am. It's always a pleasure listening to you. Once a professor, always a professor. So,
thank you, you're kind.
So, ma'am, I had two questions here. One, I wanted to know about growth hormone. So, out of all the four Poseidon groups, in your practice, in whom do you give growth hormone?
I give growth hormone, of course, the lecture apart, but I'm telling you my practical this thing.
Yeah.
That let's say she's a woman who has 2, 3, 4 antral follicles, and she says, I want my own egg. I mean, there's no way, and a very low AMH. I start stimulating her, and I find that, 2 follicles are growing. And then I see that after about 4-5 days, I find smaller follicles appearing from somewhere and growing.
Yeah.
It could be the next wave of follicular genesis. But I've noticed that if you give a growth hormone at that time, those follicles pick up. So by the time you're doing your pickup, that follicle will be 14 mm, 13 mm, 14 mm. And currently I am doing a study on follicles which are less than 12 mm, and they're giving blasts. So no follicle is small. No follicles. They're giving blasts.
Even
they're actually giving us good blasts.
Because sometimes we find that the cohort is not very good. There are a lot of follicles which are between 12 to 14, and we feel that if we retrieve oocytes from them, we will get immature eggs. But they are not immature many a times, and we
get not
oocytes from 12 to 14 mm.
So I feel every follicle is important. Every follicle is important, and I have seen that these smaller follicles, they respond to growth hormone. And this is something very definitive in my practice, that I've seen them responding to growth.
So this is after a few days of, like, say 4-5 days of stimulation.
4, 5, 6 days, you'll find the smaller ones coming up, and then you say, oh, she's got more follicles. It may be another wave coming up, but if you give growth hormone at that time, that wave picks up. So you may not get a totally 18 mm follicle there. You'll get a 12, 13, 14 there, but that gives you.
Yeah, one can try this, because this is one molecule which I haven't tried at all, growth hormone. So 4 unit you are saying every day, right?
I give 4 unit, and if she's obese, I give 8 units.
Okay. And ma'am, when we come to unexpected poor responders, would there be a difference in dealing with patients who are PCOS vis-a-vis normal, AMH?
So with PCOS, I'll tell you, if you add a LH at the time when they are not responding, and it's very common, you're giving FSH and the follicle is just not going beyond 9, 10. You call her 3 days later, it's again 10, 11. Add the LH, and the way the follicle grows is actually beautiful.
Yeah. So the LH is the molecule which gives answer in that group also.
Yes. So they could well be, maybe if you genetically test them, they could well have an LH polymorphism or a FSH problem. But we don't.
Dr. Surveen, very nice talk. I just wanted to know that polymorphism could be tested.
Yes.
Genetic polymorphism. All groups, LH variants also and FSH also. Yes. So most common one variation we get of SER60.
Yeah. They have a panel, actually. They generally do the panel.
Okay. And what's the approximate cost of this?
So the panel is a little
wanted to know.
The panel is expensive. There were some labs earlier who were doing only FSH. So that was falling cheap. Like it was about 7,000, 8,000. But the panel is about 20,000.
Panel is of 20,000. Actually, many of this poor responders or hypo responders, they wanted to know the cause why we are not getting a good
so often you test just to explain to the patient more than anything else, because you're going to increase the dose in any case next time if she's a hyper responder, but you want to test to explain to the patient that yes, this is the problem.
Yes.
Dr. Sonia Malik ma'am is also there. I
Yes,
can
yes.
see her in the
Dr.
chat
Sonia
box.
Malik is.
Ma'am, can you please unmute yourself? Any comments, ma'am?
And one of our chairpersons, Dr. Ruchira, has also joined. Dr. Sonia Malik ma'am first. Kindly, ma'am, give your views, expert views.
Ma'am, I think she might have left maybe.
I think she would be the right person. She has so much experience.
Yeah, she has a lot of experience in poor responders, but I think maybe she has just left for a
We have
while.
33 participants presently there.
Yeah. So with this, we close this session. There was one question about ovarian PRP, but I think in the chat box, but I think Dr. Surveen has answered that also, because there is no evidence in unexpected poor responders on PRP, right?
Yeah, there's
So
no
thank
evidence.
you so much, ma'am. Thank you so much for.
Thanks. Always a pleasure being with you.
Thank you. Now our next speaker. Can I start sharing my screen? Right. So our next speaker is my dear colleague from Sargangaram Hospital, Dr. Shweta Mittal Gupta. We all know her. She's the treasurer right now of the Indian Fertility Society and a very good orator. So over to her. She's going to give us the what is new in the expected poor responders, that is Poseidon 3 and 4.
Thank you, Dr. Neeti. Good evening, everyone. After a very, very extensive discussion, now we'll move on to that. What will be new? Just give me a second. When it comes to a known poor responder. So here, possibly, we kind of know that we are not expecting great results, and maybe we are prepared, and maybe we can make some strategies beforehand, unlike sudden expected poor response, which we just saw in the previous. So, despite the remarkable progress in ART management of poor ovarian responder, of course, remains a challenge. They do not respond to the ovarian stimulation invariably, and it is very frustrating when you see that card where the ultrasound picture is showing very less response, very low recruitment. You look at the estradiol levels, and the estradiol level is very, very low. Now, the prevalence can be as low as about 5.6% to as much as about 35%. And of course, there is no clear superiority of one treatment versus another one for POR to enhance the reproductive outcome. So what we have now with the new ART laws, we will definitely be seeing lots and lots of, self-stimulations. We'll be discouraging more and more of donor oocyte programs, and we would be working more on these women where we know have low ovarian reserve, but still have a decent chance to get pregnant and to have their own genetically own child. Now, several definitions were proposed to classify poor responders. We are not getting into the detail. So we started with the Bologna. It basically took into these three criteria and said any two could satisfy. Then we moved on to a Poseidon group, which said, no, we need a more detailed patient stratification. And they not only divided them as into the age groups, which is less than 35 and more than or equal to 35, but they also subdivided those who had good ovarian reserve, but suddenly showed a poor response, and those who had good reserve, a poor reserve, and showed poor response. So they had four subcategories, and out of which we now need to decide that in which subcategory the patient falls. So today I would be concentrating on group 3 and 4. We have already had a detailed analysis that how to achieve maximum results in group 1 and 2. So in group 3 is age less than 35, AFC is less than 5, and AMH is less than or equal to 1.2. And group 4 is the only difference is that here the age is more than or equal to 35 with low AFC and with low AMH. Now, the only difference here is, of course, in group 4, they are expected to perform worst because here comes the issue of more aneuploidies. So we are dealing with low reserve, but we are also dealing with more aneuploidies in group 4. So the question is that do more oocytes compromise the oocyte quality? Well, the study which just said that euploidy rate is consistently same across the number of M2 oocytes retrieved, and thus The conclusion is that more oocytes would mean more euploid blastocyst. And of course, why I brought in this slide, because there is a tendency that the moment we see a patient who is expected to have normal poor response, there is a tendency to counsel, oh, let's go minimal stimulation, mild stimulation. Anyway, the patient will form very low number of oocytes. No, that is not the concept anymore. We need to stimulate these ovaries at the maximum possible manner so that we can achieve even
The voice is gone.
Yeah, voice is gone, Dr. Shweta.
Dr. Shweta, please check your network.
Network.
Yeah, her slides are also gone.
Some network problem is there.
I'll just call her in just a minute.
She's muted.
Am I audible?
Yeah,
you're audible.
yes, ma'am. Now you're
Network was
audible.
probably creating a problem, Dr. Shweta.
I don't know.
Now we can see, yeah. Now we can see.
You start from the 5th slide again, I guess.
Yeah, I've put in my ART calculator. Is that visible?
Yes.
Yeah. So using ART calculator, of course, is preferable because the whole concept is that if the age is less than 35, we are expecting about 6 oocytes. Around 5 would be mature, 4 could fertilize, and you will still get 2 blastocysts, keeping a euploidy rate of 60%. Even with 2 blastocysts, you can counsel the patient that yes, you will have a 60% chance that this embryo will be euploid and will implant. Now, if you go to the age 39 to 40, you would roughly need about 11 oocytes, because assuming that 9 are mature, 7 fertilize, will form 3 blastocysts, keeping a euploided rate of about 30% in this group. If you have 3 blasts, you can still have a single euploid blastocyst. And coming to 42 to 43, see the number of oocytes, what you would be requiring, how will we ever reach, how many cycles of IVF they would need. 18 oocytes, maybe 16 mature, 13 fertilized, 5 blast, keeping a euploidy rate of 20%. There is only chance that out of these 5 blasts, 1 is euploid. So it's so important that we need to optimize the stimulation. Now, in the Poseidon group classification, just a second. Patients belonging to group 3 and 4, they will share the common features of poor ovarian reserve, which independently of age renders them at high risk of poor reproductive outcome. So what you need to do, you need to make a pre-treatment strategy. You need to change their ovarian stimulation. Maybe you need to give them some adjuvant treatment. And what is the ovulation trigger strategy in order to optimize the probability of having at least 1 euploid blastocyst for transfer. So currently, tailoring the controlled ovarian stimulation will be based on daily different dose and type of gonadotropin, whether to use antagonist or should we go back to agonist. What should be the final trigger of maturation, HCG, agonist, both? What are the newer ovarian stimulation protocols? And whether embryo selection is conducted through PGTA, but this is out of the scope of my talk today, so we would not be discussing it. Although several strategies have been proposed aiming at maximizing the ovarian response and success in poor prognosis patient, no standard management has yet been outlined, and that is why you will see 10 prescriptions with 10 different protocols. Poor ovarian response to stimulation is one of the most difficult situations in IVF cycle. However, what we need to look at is increasing the clinical live birth rate. So starting with natural cycle and mild stimulation, I will just show you the data. Data by Polizos and Kedem et al. Said natural IVF cycle brings extremely low live birth rate in POR patients with a reported live birth rate per cycle of only 2.6% and a cumulative live birth rate of only 7% after 6 natural IVF cycles in the Bologna POR patient. Thus, a gain in 1 oocyte increases the pregnancy rate by 5%, and thereby choosing a natural cycle, mild stimulation, adding a very low dose gonadotropin with clomiphene or letrozole should not be the strategy for these patients ideally. So ovarian stimulation rather than natural cycle should be preferred first-line treatment in poor prognosis patient with a poor ovarian reserve. What about pituitary suppression regimes. Now we can see that GnRH antagonist was used in about 53% of patients, with agonist in about long agonist protocol in 9%. This was a survey from 196 centers involving 45 countries. Now, the print trial said that down-regulated cycles slightly brought about better oocyte retrieval rate as compared to the agonist short regime and as compared to antagonist regime. No. So basically, when you compare agonist to a short agonist regime, a long agonist regime brought in better result, and agonist and antagonist brought in the same result. And that is why you can choose between agonist cycle or an antagonist cycle. But an agonist short regime, that is starting from day 2 of the menstrual cycle, is not a good option for poor responders. Now, looking at similar live birth rate, which was seen in patients who were given antagonist as compared to those who were given an agonist cycle. If you can see the forest plot, the diamond is more towards the center. So there was no significant difference in the live birth rate, 3 RCTs with a relative risk of 0.89 and 95% confidence interval. So the bottom line is that for these patients, you can choose either an agonist standard downregulated cycle or a standard antagonist cycle. Now, there was a meta-analysis in 2011 and 17, which said both agonist and antagonist cycles brought in similar live birth rate, but an RCT conducted by Shesh Sankara in 2014 said that in sudden unexpected POR, that means in patients who have had very low or disjointed cohort, the next cycle, you can choose an agonist cycle. It did increase, though not significantly, but it did increase the number of oocytes in agonist cycle. So if you have had a bad experience in these patients on that cycle, the next cycle can either be a luteal phase priming followed by your gonadotropin and antagonist cycle, or you can go back and do an agonist cycle expecting a little better oocyte recovery in case you had a poor cohort coming up in an ANTAC cycle. So to bring similar results in agonist suppression, can we use luteal phase estrogen or oral contraceptive pills? So Blockhill et al. Said that this could be an alternative regime. Use them for day 12 to 14 days as a pre-treatment. So you can choose between two. If you know she's a known poor responder, either you can give her a luteal phase estrogen and progesterone or an OC pill, or you could use a GnRH agonist cycle, but do not use OC pill for long periods because it can bring a lot of suppression and suddenly there would be a difficulty in basically bringing up more follicular recruitment. But what is the advantage? See, when we, do a lot of studies, 11 POR cases would need to be treated to actually obtain one additional clinical pregnancy. So though it does sound rosy, but in practicality, maybe, even a luteal phase priming may not be that helpful, but though it does not harm the patient so much, so in order to make a better cohort, you can do that. There is no data on live birth rate provided when it came to using luteal phase priming or not using them. Now coming to stimulation regime. So we have moved from natural cycle to down-regulated. We have seen antagonist cycle and we have seen data on luteal phase priming. What about stimulation? Which gonadotropins to start with? Should it be recombinant FSH? Should it be recombinant FSH with recombinant LH? Should it be HMG? What dose to use? 225, 300, 450, 600. I've also seen prescription up to 900 unit. So this was a retrospective study of Poseidon group of patients who reported a higher live birth rate per initiated cycle achieved in group 3 patients by using HMG in a GnRH agonist down-regulated protocol as compared to HMG in an antagonist protocol. It was Huang et al. This was published in 2018. However, another retrospective study which compared 999 poor prognosis patients, but here their AFC count was way higher, though the AMH was all right. In the long down regulation protocol and comparing recombinant FSH and recombinant FSH to HMG showed that LH with FSH was superior to HMG in regards to the clinical pregnancy rate per started cycle, 12.5% versus 8.1%. However, which is the subgroup of patients, which is older women, more than 35 years of age group, where recombinant FSH and LH will improve the implantation rate. So 35 to 39 years and above, they said it was an RCT which compared FSH 300 versus 225 unit plus 75 unit of LH and showed a better implantation rate as compared to only the recombinant FSH group. The available evidence then suggests that RLH exerts a beneficial effect in terms of implantation rate in women aged 36 to 39, regardless of the pituitary suppression protocol. Nonetheless, no effect in terms of pregnancy rate, which was observed. No significant effect was observed in studies in women aged more than 40 years who were included in the group receiving an agonist or an antagonist regime. Now, in older women, this would improve the implantation and pregnancy rate. So basically, systematic review, including 70 articles, 34 studies compared FSH versus FSH plus LH. All the participants were in the age group of around 33 plus or minus 3 years. So FSH alone results in high oocyte number. HMG improves the collection of mature oocytes and embryos and increase the implantation rate. On the other hand, LH addition leads to higher pregnancy rate. So 6 RCTs on LH activity in women aged using agonist and 4 RCTs using antagonist. They said that LH activity exerts a beneficial effect in terms of implantation rate in aged women, regardless of pituitary suppression protocol. So if we are looking at group 3 and especially group 4, so I would suggest that using a higher dose of gonadotropin and adding an LH activity from the beginning of the cycle is something which can be considered. Now, a meta-analysis comparing 70 prospective studies, all gonadotropin combinations and all ART outcomes reported recombinant FSH alone resulted in greater number of oocytes than HMG or recombinant FSH and RLH. Now, the concept is that by using recombinant FSH, you are increasing more granulosa cell activity and possibly more mitotic activity, and that possibly results in better oocyte recruitment. But addition of LH is useful to reduce the amount of dose of FSH, and this I have been using now in my clinical practice. Ever since I've been using Pergoveris, what I have started doing is that in my poor responder, I add a dose of clomiphene along with gonadotropin, and I have started reducing 75 unit. And now I'm seeing that in the same patient where I had to use 300 unit, if I add clomiphene and I reduce the dose to 225 unit, possibly I'm achieving the same result. But of course, we'll only come to know in certain time when I've used it in more number of patients. If that is possible, then yes, you will be able to use a standard combination of recombinant FSH and LH with some increase in the cost, but not a tremendous increase in the cost and with the same results. So recombinant LH induced modulation of the pKa activity and proliferative activity, not an anti-apoptotic signals, unlike HCG-driven activity in HMG, possibly should be better in this group. Now, as regards to the maximum daily dose of FSH, it was shown that recombinant FSH dose above 300 unit does not seem to increase live birth rate. Now, this was a very large retrospective study of about 6 lakh people, and they said that more than 300 unit, including both FSH or urinary and RFSH, decrease the odds of live birth rate. So we do not need to pump these patients with gonadotropin, which is going wasted in the body. And we just need to titrate it in the maximum dose, which is around 300 unit. Now, a word about adjuvants. Now, there is absolutely, in terms of evidence, not much role of any other adjuvant. The recent which has come up is Q10. The problem with CoQ10 is that there are very inconsistent studies. There are no dose-defining studies, so we need much more data. But whatever is the small data, we said that 60 days prior treatment, which was investigated in Poseidon Group 3, the hypothesis is that CoQ would reduce the mitochondrial oxidative stress and improve the oocyte competence. The study showed that a significant decrease in the difference in the CoQ supplemented group regarding number of oocytes. The mean was about 4 as compared to controls, which was about 2 with more high quality embryos. But of course, the major limitation is lack of placebo group. Lot of studies of CoQ have come from the Chinese group, where they have also used parallel Chinese medicines. There is no dose defining study. So we need much more studies when it comes to CoQ enzyme. But the only point is that not much of a side effect and can be given. However, these are also expensive drugs. Now, the last part of my talk is discussing double stimulation in poor responder. Well, double could mean double chance of pregnancy. Yes, sounds possible. And the studies showed that, well, more M2 sites, more top quality embryos, and more, cryopreserved embryos when you did double stimulation. So this means 2 cycles. So pooling of embryos by double stimulation. So double stimulation could increase the chance of achieving the pregnancy by accumulating more oocytes embryos in a short time, which might serve as a useful strategy for older women. Now, moving on from double stimulation has emerged dual stimulation, duostim. What is the physiological basis? What is duostim and how to perform it? We will very soon from Gangaram Hospital will be having a published data. So I've not brought in that data right now, but we can clinically share our experience. Now, the physiological basis, I'm not getting into the detail, that every menstrual cycle can have 2 to 3 distinct follicular waves, and these follicular waves can happen in the same menstrual cycle. This concept has definitely overcome the previous dogma that follicular phase will only have follicular growth and nothing else. So the first wave can happen in follicular phase, and a second wave can also happen in luteal phase. So the ovarian follicular, this diagram only shows that there are 2 to 3 follicular waves happening in the patient. And the first diagram is 2-wave, the third is 3-wave cycle. Ovarian follicular development, physiological basis of duostim. Novel protocols have been theorized based on the use of gonadotropin to prompt the growth of antral follicles at any stage of menstrual cycle. And duostim appears to be one of the most promising stimulation protocols. The bottom line is that it increases the number of oocytes retrieved and embryos produced in a short time frame. So here, double stimulation in a single ovarian cycle, where you combine a follicular phase stimulation along with a luteal phase stimulation. It is a good strategy for patients with reduced ovarian reserve, advanced maternal age, to maximize the number of oocytes. For patients who did not collect oocytes or did not produce competent embryos after a conventional follicular phase, and it suits poor prognosis and oncological patients. So what you will do, 2 successive ovarian stimulation, please understand there are multiple regimes. Now just follow this diagram. She comes during the menstrual cycle. It can be a standard gonadotropin cycle. You give the standard fixed dose protocol of antagonist. The final trigger can be agonist, but we have also seen that giving an HCG trigger doesn't really hamper anything. You've done the egg collection after 35 to 36 hours. After the first oocyte retrieval, now either you can give vaginal progesterone to the patient, or if you have really thought that the number of oocytes you saw were very less and you have to give another stimulation. So after 3 to 5 days, either you can start randomly the second dose of gonadotropin, and even after, so in the second dose of gonadotropin, when the follicular size has reached 13 to 14 millimeter, you can add your antagonist. The second trigger can also be an agonist, and you can do the oocyte aspiration the normal way. The second modification, what we have done in our hospital, is that we have started giving medroxyprogesterone 10 milligram once daily after the first oocyte aspiration. We start the gonadotropins after 3 days. We also added letrozole, but somehow the other, in few cases, we realized that maybe it was not really bringing better embryo conversion. We stopped that. Then you need not give antagonist in the second cycle. You keep monitoring the patient. You call the patients after 7, 8 days of gonadotropin. No need to call before that. No need of an ultrasound. Yeah, after oocyte retrieval, the first one, no need of any hormonal test. Now, after 8 days, you will see certain aspirated follicles and you will see a new cohort of follicles coming in. Follow that, follow it up with estradiol levels. Keep continuing MEPRATE till the second trigger. The second trigger can be an HCG trigger, it can be a dual trigger, it can be an agonist trigger. Give your gonadotropin the way you are giving. Adding a recombinant LH in the second cycle somehow slightly looks better along with FSH. These people will take anywhere between 2 to 5 days of extra gonadotropin and do your routine aspiration after 36 hours, the way you have done it for the first cycle. It's a mandatory freeze-all cycle because the endometrium is now exposed to progestogen and the endometrial stromal dyssynchrony is there. So this I have already told you. So there are multiple regimes you can use. And what is the clinical evidence and reproductive analysis? Let's see the SWOT analysis. There are a huge number of data. The Kuang et al. Was the pilot study. They all said significantly more oocytes after luteal phase. Obaldi's group is the one majorly doing work on it. They said more number of oocytes. Same euploid rate, so luteal phase stimulation was not bringing inferior embryo conversion at all, and there was an increase in more than one euploid embryo. Let's go to the other analysis. Again, studies by Zhang, Russian, and Zhang et al. Said more oocytes, more embryos in the luteal phase, and higher implantation rate. Though what we need to analyze still is that when the embryos are formed, in the follicular phase and luteal phase, which were the embryos which were consumed first, depending on the morphology, and what was the pregnancy rate which you got when you transferred the follicular phase embryos as compared to the luteal phase embryos. I'm talking in relation to the study, what we have done at Gangaram Hospital. Now, there is only one, study. Again, this is again a band of studies saying better oocytes and better embryo conversion. And then out of this, there is one study which said that significantly less number of oocytes with luteal phase. There was an oral presentation which was done in ESHRE last year, which has compared, it was the only RCT which compared one follicular and two follicular phase stimulations versus follicular luteal phase. And they found in their study same numbers of oocyte and embryo conversion, and they did not find that luteal phase was better than the follicular phase. But in our own study, we are finding a 60% gain in terms of number of oocyte or embryo conversion when luteal phase is adopted. So the strengths of duostim is higher number of oocytes and embryos obtained per ovarian cycle, more patients obtaining more competent blastocysts per ovarian cycle, and no difference between the oocytes between FPS or LPS. Weakness, of course, is higher number of stimulation, days of stimulation, no RCT, freeze-all approach, and applied only for poor prognosis patients. Opportunities is reduced time to obtain at least one competent embryo in a single menstrual cycle, better tolerated. Well, the threats. Let's come to threats. Cost effectiveness, increase in total dose of gonadotropin administered, then the conventional COS, few biological, gynecological, obstetrical, and neonatal evidence when it comes to safety. So BioStim, the first RCT comparing duostim, which I just said, let's just read that there was no additional benefit. This was the only one which was presented in ESHRE. Last talk is final trigger. Well, achieving the maximum number of mature oocytes can be improved not only by the use of COS protocols, but you need the best LH activity, which is trigger. A previous cycle with low follicle to oocyte ratio could reflect lack of appropriate follicular response to trigger, which could be associated to ovarian aging, poor ovarian reserve, or even to mutations of LH receptor. So dual trigger, which is combined use of agonist and HCG simultaneously and performing oocyte retrieval the same way. And double trigger is where you give agonist earlier than your HCG, so 40 hours before the oocyte aspiration, and HCG is given 34 hours before oocyte retrieval. Both strategies combine the advantage of agonist and HCG, which directs the intrafollicular LH activity mediated by HCG. Just let's see the evidence. The physiological rationale being that some patients may need a longer exposure time to the ovarian trigger agent to allow cumulus expansion and detachment of oocyte. There are very low number of studies only for Israel. So yes, dual trigger can be considered. This is a little algorithm that in the end, if AFC is less than 5 and AMH is less than 1.2, what you can do is see the age. If less than 35 years, you can think of adjuvant treatment. More than 35 years, well, debatable. If they have been given, you can, the adjuvants are androgen growth hormone CoQ10, though not much evidence in this group on other two other than CoQ. You can give a long protocol. You can give E2 or OC pre-treatment and duostim. In the second group, androgen growth hormone, you can do long protocol, E2 or OC pill, pre-treatment and antagonist and duostim. In Poseidon group 3, 300 units of daily FSH, or you can give HMG or recombinant FSH. In the Poseidon group 4, they ideally need recombinant
Dr. Shweta, it is again stuck. I think again stuck. I think this was
You're
the
not
last
audible,
slide only.
Dr. Shweta.
Dr. Shweta. I think she reached her last slide only. A connection is lost, but she reached her last slide. A very comprehensive, talk on expected poor responders. This is the group which we are going to handle now. Now that the donor recipient cycles are in a mess. So now we are honored to have Professor Ruchira. Professor Ruchira is there, Dr. Ritu?
I'm there.
Professor Ruchira there?
Yeah.
Professor Ruchira, I invite Professor Ruchira to introduce the next speaker, Dr. Ritu Prasad. Professor Ruchira, please. Can you unmute
Dr.
yourself,
Ruchira.
Professor Ruchira?
I think she was in OT actually.
Okay.
She must be busy.
Let
She
me have-
messaged me.
So I take the honor of-
And in AIMS connectivity problem is coming. Dr. Jaya also messaged me.
Okay.
Dr. Latika Chawla is also one of the panelists from AIMS only. Na? So weather at Uttarakhand is bit stormy today. So connectivity problem is there.
Okay, so I take the honor of introducing you, Dr. Ritu. So Dr. Ritu is a gynecologist, infertility and IVF specialist from Prasad Hospital, Rishikesh. And she's secretary of the chapter secretary of the IFS Uttarakhand. And she's going to speak on the medical legal aspect of the donor recipient cycle.
Thank you. Thank you, Dr. Neeti. And the talk of Dr. Shweta was very good, especially her insights into dual stim were very good because and her experiences also. Hope we have been benefited from her talk. And now I switch over to my talk of a very important talk. My screen is visible?
Not yet, Dr. Ritu.
Okay.
Try to make it full screen.
Okay. Now it's visible?
No.
No, okay. Just wait a minute. एक second. Problem. One minute. I'll start. Your screen is paused. It's coming. Screen sharing is paused.
Himanshu, please help Dr. Ritu.
So today my topic is medico-legal concentration with donor-recipient cycle. This is a very burning topic. Actually, with the passage of ART bill in the Lok Sabha and Rajya Sabha and many of the strenuous act, this has been we are looking forward for this medico-legal aspects. So what are basically oocyte and embryo donation? Oocyte in oocyte donation, apart from the oocyte, donor oocytes, husband semen is necessary for fertilization. And in embryo donation, it obviates the necessity of using the husband semen. The choice of oocytes and embryo for oocyte or embryo donation depends entirely on circumstances prevalent at the time the infertile couple comes for treatment and the access to the infertile clinic for frozen oocytes or embryos. What are basically indications of oocyte donation? In cases of gonadal dysgenesis, premature ovarian failure, iatrogenic, women who have resistant ovarian syndrome or who are poor responders to ovarian induction, women who are carriers of recessive autosomal disorders, women who have attained menopause. Our recipient, what are the requirements of a recipient? Recipient should be a healthy woman determined by medical or psychological examination, having a normal genitalia. In case of oocyte donation, the semen characteristics of the husband must be determined to see if they are in conformity with those associated with normal fertility. Donors, what are the requirements for the donor? Donor should be healthy as determined by medical and psychological examination, age group between 18 to 35 years. She should be properly screened for all sexually transmitted disease, absence of HIV, HPS, AG, and HCV antibodies, etc. She should be married and having 1 or 2 children. Should be known or mentioned. And if she is divorcee or widow, the divorce certificate or the certificate of husband should be attached with the documents. This is the oocyte donor form in which the name, donor ID, marital status, education, occupation, religion, obstetric history, her height, weight, color of skin, hair and eyes, etc., or smoking or any drinking habits, all are mentioned. And this is the IVF egg donation consent form, which has to be duly signed by the consent कि मैं अपनी स्वेच्छा से कार्य कर रही हूँ और मैं अपनी इच्छा से आई हूँ. यदि पिकअप के बाद थोड़ी बहुत तबीयत खराब होती है, उसके लिए उल्टी चक्कर आना आदि सब मुझे बता दिया गया है. इंजेक्शन शुरू होने से पिकअप होने तक की सारी जानकारी मुझे दे दी गई है. एंड दिस इज द रजिस्ट्रेशन बाय द नोटरी, शपथ पत्र, which has to be signed, in which the name, Aadhaar card of the donor is mentioned. And मैं भारतीय अधिनियम के तहत कानूनी रूप से विवाहित हूँ और मेरा अपना बच्चा है और हमारा परिवार पूरा है. हमें अगले वर्ष कुछ वर्षों तक किसी भी बच्चे की योजना नहीं बना रहे हैं. अगर पिकअप के दिन मेरे पति मौजूद नहीं है तो मेरे परिवार का कोई भी सदस्य मेरे साथ आएगा. This is all the शपथ पत्र which has to be signed duly by the donor, and this has also to be signed by the commissioning couple also. This. There is a growing interest. What are the possible misuse of this this donor cycles? Why the need of ART bill was there? Because there is a growing interest in the embryonic stem cells because of the pluripotent characteristic used for developing spare organs, replacing defective tissues such as brain destroyed by Alzheimer's disease and pancreatic cells in diabetic patients. The range for the potential use is limited only by one's imagination. ART clinics are the only source of embryonic stem cells. Spare embryos are either frozen or donated to other infertile couple or discarded after 5 years using a suitable protocol. So there was a need to law to intervene. For years, ART sector followed the ICMR 2005 norms, but it was tutored by in 2020 by the then health minister, Dr. Harshvardhan. The ART bill, it was in the need to regulate the ART services, mainly to protect the affected women and children from exploitation. The USAID donor need to be supported by an insurance cover, prevent multiple embryo implantation. Children born through ART must have equal to biological children. Cryopreservation of sperm, oocytes, and embryo by the ART banks need to be regulated. The bill intends to make PGD mandatory for the benefit of the child born through ART. So thus regulating the ART was very much important, and the bill establishes the national board, state boards, and national registry. It proposes stringent punishment for those who attempt to control offspring sex determination, cell embryos, or gametes. This is the Gazette of India, Bharat Ka Rajpatra. This whole bill is available on this site. So few important highlights of this bill, which was put in Rajya Sabha on 18 December in 2021. The main aim was the bill was regulation and supervision of ART clinics and bank, prevention of misuse, safe and ethical practices of ART services. So this bill has 6 chapters and 46 clauses. What a few definitions are important. What do you mean by the ART bank? Means an organization which shall be responsible for collection of gametes, storage of gametes and embryo, and supply of gametes to the ART clinic or their patients. ART technology clinic means any premises equipped with requisite facilities and medical practitioners registered with the National Medical Commission for carrying out the procedures related to the ART. One important definition is this, because we refer our patient, infertile couple, as commissioning couple, means an infertile married couple who approach an authorized ART clinic or bank. What authorities that regulate ART? There are 3 authorities, main authority: National ART and Surrogacy Board, State ART and Surrogacy Board, and next is National ART Surrogacy Registry and appropriate ART and Surrogacy Authority. What do you mean? This national board is established under Section 15 of the Surrogacy Act, and National Registry under Section 9. Registrations of ART clinics and bank. What's the use of registering? Only registered clinics and banks could do ART practice. Application to be made at National Registry. Approval of appropriate authority is necessary for every clinic or bank. Appropriate authority can suspend or cancel the registration. What are the duties of ART clinics and bank? Their duties ensuring eligibility to avail ART procedures, providing support and professional counseling to the commissioning couple, obtaining donor and gametes and ensure that donor is medically tested, ensuring confidentiality of the involved parties. What are the general duties? Maintaining a grievance cells for complaints, applying ART services, ensuring discharge services, and providing information to the National Registry related to enrollment procedures and outcomes. Clinics and banks are not allowed to perform procedures without consent and insurance coverage. Insurance coverage is nowadays mandatory. 12 months insurance coverage has to be given to the donor, and insurance form I'll tell you later has to be duly made by the insurance agent. Engage in cryopreservation without consent and instruction. We should not cryopreserve any of the embryos without the consent of the commissioning couple. Use human reproductive material to create human embryo. We can't use any human embryo without the specific consent of the commissioning couple. And commissioning couple can withdraw at any time before transfer of embryo of gametes to the uterus. So all clinics and bank must maintain a detailed records of all donor oocytes, sperms, and embryo. submit progress reports to the National Registry, submit information pertaining to the number of donors to the National Registry. Records must be maintained for at least a period of 10 years, except under special circumstances. If there's an advent of closure of the clinic, then it has to be transferred to the central database of the National Registry. And this, all 3 points are important. Not more than 3 oocyte or embryos to be placed into the uterus of the women. Gametes or embryos are derived from only one man or women. No mixing of semen of 2 individuals is allowed. What are the implications of capping on number of eggs that can be retrieved? Now, in the latest ART bill, a donor in the latest ART bill, a professional egg donor can donate 7 eggs once in a lifetime. So this is the latest, like a donor can give only 7 eggs once in a lifetime. This is coming latest in a ART bill. Embryo splitting is prohibited. Donation of embryo for research can only be done when the embryo has pre-existing heritable, life-threatening or genetic disease, and when there is approval from the commissioning couple. Then only the embryo could be taken for the research process. Clinics are not allowed to offer a couple sex determination. Helps to increase the probability of the embryo shall be of particular sex, separate or yield fractions enriched in sperm, X or Y variations. Regulation for donor banks. Banks must be registered. Male donors should be in the age group of 21 to 55, females in the age group of 23 to 35 or 18 to 35. Sperm or oocyte of single donor to only one couple, and oocyte donor can donate only once, up to 7 oocytes in a lifetime. So storage maximum for 10 years, central government defines a standard. Sale, transfer, use of gamete zygotes without permission is strictly prohibited. Rights of child born through ART entitled to corresponding rights and privilege only from the commissioning couple. Donor must relinquish all parental rights. Offenses and penalties, what are engaging in activities pertaining to the facility of sex selective ART, abandoning, disowning, exploiting the child born through ART, exploiting the commissioning couple or gamete donor, transferring human embryo into a male person or an animal, using any intermediates to obtain gamete donors or purchase gamete donors. Individuals found guilty to involved in such activity would be subject to fines up to 25 lakhs or imprisonment of up to 10 years. So in our opinion, will there be any challenges in the following these clauses laid down by the ART bill? Surely it will be many challenges and we have to face them. And the more we are used to with this ART bill, the more it will be helpful in our daily practice. So what are the challenges? Doctors say that would lend to higher treatment cost. Renewal of the registration is high at 1 lakh to 5 lakhs depending on the ART clinic. Professional egg donors can donate 7 eggs once in a lifetime. No mechanism is mentioned in how to check the egg donor's claim. Single persons cannot seek surrogacy. Sex selective ART will be punishable. Clinical applicability of the ART bill. Platform for clinicians to suggest their inputs to improve ART. Better understanding of the patients, better understandings of the clinician role in ART. It will help to reduce the malpractice and foster a stable environment for ART, helps to avoid confusion and streamlines the treatment process, this ART bill. This is the insurance policy which has to be formed, which has to be filled by the, which has to be done for the donors. And commercial surrogacy is totally banned in India by the government through the bill passed on 25th December 2021. Now foreigners can't hire WIMs in India. So have there been noticeable improvements in ART since introduction of the ART bill? So I'll need comments from the experts after this, my lecture. Has there been any significant changes in your practice after introduction of ART bill? This is also open for discussion. Do you think that this ART bill will impact the adoption or orphan children in our country? If so, how? Yes, it can affect. People may adopt more towards adoption through this ART bill. Thank you.
Thank you so much, Dr. Ritu. A very comprehensive talk on the medical legal consideration of donor recipient cycles and very pertinent questions which you have asked. Any comments, Dr. Nymphia? Or any
No, I
of the
think it was very well covered by Dr. Ritu. And as far as this, the questions which you had asked, which were open for house, probably yes. Banning of surrogacy might, and the legal hassles attached with surrogacy might incline people more towards adoption in our country. And but as far as donor practice is concerned, with the paperwork involved and putting everything into place, we are proceeding with donor cycles. But of course, surrogacy is still has taken a backseat. So let's see how it progresses. Once people come, there are many papers.
Yeah, one
And
thing
also the donor sharing is not allowed nowadays.
yeah,
no?
one
No.
thing which I feel might change, over the time, which is in a positive way after this donor recipient, laws which have come, is that people will be wary of stimulating the donors now. Like, we know that donors were stimulating to produce 30, 40 eggs and then sharing
Yes, yes.
for patients. We cannot deny, that this was not happening. This was happening. And this, law will put a restriction to that. Now, because now,
Yes.
you will stimulate less, because if your patient has a problem, then you will have a bigger problem. If your donor ends up with a medical problem, you will have a bigger problem then. And because sharing of eggs is not allowed, so there is, why would you take out more eggs? So now the stimulation of donors will be milder after this donor recipient, this thing, law which has come up. So thank you, Dr. Ritu. And
Yes.
now we go on to our interactive panel. Looking forward to or interacting with all the panelists. So it will be moderated by me and Dr. Nithya. We are the co-conveners of the SIG of Poor Ovarian. The panel discussion is on let's talk about our experience. We have read a lot, heard a lot about what is the evidence say. Now let's see what we do in our day-to-day practice to manage these patients, right? So for this, we have very eminent panelists with us, starting with Dr. Leena Wadhwa, who is a professor and in charge reproductive medicine and surgery, ESI Basai Darapur, and she is the IFS joint treasurer in Indian Fertility Society. Then Dr. Shalini Chawla Khanna, who is a senior IVF and laparoscopic consultant with Max Hospital, and she's also the general secretary of Delhi Gynae Forum South and executive members of Indian Fertility Society. Then Dr. Meenu Vash, who is at present the president of Uttarakhand Society of Obstetrician and Gynecologist, and my old friend, Dr. Meenu, welcome on board. And Dr. Renu Tawar, professor and IVF coordinator from Department of Obs and Gynae, Maulana Azad Medical College, New Delhi. She has agreed to come on our panel. She'll bring out the views from the public sector in IVF. Then Dr. Latika Chawla, who is also from the public sector. She's associate professor, Department of Obstetrics and Gynecology, AIMS Rishikesh. Welcome, Dr. Latika. And Dr. Akriti Gupta is assistant professor Obs and Gynae from Sri Mahant Indrash Hospital, Dehradun, a young practitioner. And Dr. Aditi Gupta, who is basically working at Ashirvad Fertility Center and Metro Hospital, Haridwar. Welcome aboard all the panelists. And then with this, we start the panel. Dr. Nymphia.
So through all the lectures, of course, we've understood that the primary goal of ART is to achieve a singleton live birth in the shortest time possible. And the best way to achieve is to transfer a single euploid embryo at a blastocyst stage. So as early we are able to do it, we can achieve a pregnancy. So an appropriate ovarian response to ovarian stimulation is very crucial, and the number of oocytes retrieved is strictly related to live birth rate. Based on these markers, of course, we have normal, hypo, poor, or hyper responders. There is a specific subset of hypo responders which we are discussing through this webinar we've been talking about. So we have understood this Poseidon concept. There are 4 types of groups. 2 belong to the expected poor responders and 2 to the unexpected poor responders. This Dr. Shweta had explained very well that how each and every oocyte increases the chances of live birth rate by around 5%. And what is the number of good quality oocytes which we need at different age groups to achieve that one euploid blastocyst. So what is the relevance of Poseidon in our day-to-day clinical practice? Dr. Akriti.
Hello, everyone. Thank you, Nymphia ma'am, for the wonderful introduction for all our panelists. I'm actually privileged to be a part of this extremely expert panel, and I'll be sharing a few of my clinical experiences here. So, ma'am, question you've asked me is that the relevance of Poseidon in our day-to-day clinical practice. Actually, if we see the Poseidon criteria, it has helped us to classify even those patients which were the unexpected poor responders. So, in short, so we kind of see if the AMH and AFC sometimes is fine. And as we start the cycle, we observe on the 3 days of stimulation, the response is a little lesser, or that is where we can take into practice the Poseidon criteria. We can fit into it and see if they're falling into 1 or 2 group of hyper responders, and, how we can rescue that cycle. Like, how we can rescue that similar cycle. Similarly, the actual poor responders, we already know that the actual poor responders will be helping us. We will be taking care of the actual dose of gonadotropin to be started at 300, or adding adjuvants to them, or adding again, how to make best use of, for that ovarian cycle for the actual poor responders, that is the group 3 and 4. So they actually take into consideration the oocyte number. So previously what we were doing was Bologna criteria, we were not taking care of the oocyte number, the number of oocytes which was retrieved, and there was no homogeneity of data irrespective of the age, because some people who were less than 35, they were also having poor response, unexpected poor response. So Poseidon actually has given us a homogeneous pattern in terms of how we can divide these unexpected poor responders also, and how we can rescue those cycles. Along with, actually, we were having the actual poor responders already, we were treating them. So similarly, 3 and 4 are the actual poor responders where we are treating with a similar fashion. So ma'am, I think it has helped in our practice to take care of these difficult situations during the stimulation when we see the unexpected response of a suboptimal or hypo response. So either of the two.
Yeah. Thank you, Dr. Akriti. I think so. We both our start and the treatment become more accurate with the Poseidon group. So diagnosing, counseling, and the treatment. So we can be very specific without failing one cycle and then taking a decision for the next time. Okay.
Moreover, it is easy to counsel our patient. We can tell them you are in that group, and so this is your problem. What we expect from you, and we can make tailor-made decisions depending on the Poseidon classification.
Absolutely right, Dr. Meena. So, Dr. Aditi, what is an ART calculator and how does it help us in clinical practice?
Like this ART calculator, which shows that how can we calculate the amount of eggs? How can we calculate how many oocytes are required to make a one euploid embryo? So with that number of eggs, we can calculate how many oocytes are required for a particular maybe poor responder patient or maybe a normal responder patient. So those kind of calculations are used with the ART calculation. Like in our previous lecture, we have understood with that the higher the age of the patient, higher number of oocytes are required to make the euploid embryo. So that is what that is used for.
So basically, ART calculator has two parts. There are two predictions. One is a pre-treatment estimation that it is for counseling. That you tell the patient that this is the number of mature oocytes we'll need to have at least that one euploid blastocyst. Another is after we know the oocytes, So it uses the actual number of collected oocytes and estimate the chances. And we tell them, yes, this is the percentage chances that you will get a euploid blastocyst. All right. We've done this. Okay, so this is a panel. Now we have all our esteemed panelists. We'll combine our clinical expertise, best evidence, and share our experiences. So the first case, Dr. Neeti will be handling the first case.
Okay, so starting with the first case panelists, it is about Mrs. RK, who is a 27-year-old lady. She presented with unexplained infertility of 5 years. She had 4 cycles of ovarian stimulation with clomiphene and IUI in the past. After that, she went through 1 cycle of gonadotropin IUI also, where she made 2 dominant follicle with HMG 75, but failed to conceive. She has a BMI of 25 kg per meter square, an AMH of 3.1 nanogram per ml, and AFC of 14. Semen parameters are normal. And because she had a long infertility with failed IUIs, we decided to take her up for IVF. So on day 2, 225 units of recombinant FSH was started in antagonist cycle. And this is the response we get after 5 days of stimulation. So Dr. Leena, what do you think about this response after 5 days of stimulation?
Yeah, as we can see from the chart that after 5 days, the growth is asynchronous.
Dr. Leena, we can't see your face. We want to see your
face. Okay, my video was switched off.
Yeah.
So yes, Dr. Neeti, as we can see that in this both ovaries, they're showing asynchronous growth on the 5th day of cycle. The follicles, they are ranging from 4, 5, 6, 6, 6 and up till 14 millimeter. And comparatively, estradiol level is also low. So it is a kind of hypo response.
Okay. Dr. Shalini, how is a hypo responder different from a poor responder?
Okay, first of all, thank you, Uttarakhand and Neeti, Nymphia, and Dr. Suveen and Dr. Kiri and Dr. Ritu for giving this pleasure. Now, in this, yeah, am I audible?
Yeah.
Yeah, okay. Yeah. So in this patient, now we see that the response is less. So, as the terms itself justifies hypo. Hypo means less. So hypo responder is different from the poor responder in the sense these hypo responder patients, they have normal ovarian reserve. The FSH would be in the normal range, would be close to 6, 7 or 8. AMH would be good. And when you stimulate, they will take long time to get stimulated. The estradiol levels will be less. There will be a slow response in the stimulation. And the dose of gonadotropins will be much more. So they differ from the poor responders because the poor responders, we know that they have decreased ovarian reserve. They have, like, as per the Bologna criteria, the AFC count would be less than 5 or AMH would be less than 0.5 to 1.1. But these hypo responders, they have normal everything. It's the response which is very less. And why should there be a hypo response with normal
clinical practice? This is why when you find a hypo response, what are you looking for? Why was there a hypo response?
Yeah, so there could be many causes for the hypo response. One, it could be the starting dose could be less in these patients. The other could be, we have to maintain the cold chain properly, has to be maintained. The other reason could be, which strikes our mind after listening so much from the talks in the morning, that there could be receptor polymorphism, either because of the genetic mutations or the single nucleotide polymorphism. We have started seeing these lot many since we know, like the eye see what the mind knows. So since we know that there is a polymorphism, there could be a polymorphism in either in the FSH or in the LH receptors, which leads to the decrease or the hypo response.
Or could there be a technical issue also, like a new operator maybe, or who is doing
Neeti, this we are talking about the stimulation. I mean, that is, yes, certainly the technical would be when we get the decreased number of oocytes when we are doing the pickup. But as of now, during the stimulation, when we are talking about it, we are seeing that the response is less. And probably there is an asynchronity also. So during the stimulation, these are the kind of maybe the patient requires LH, which like maybe in the next cycle, or maybe what if we have to do salvage this cycle, then maybe we can add LH in this cycle. So that is how we can rescue these hypo responders.
Yeah. Dr. Renu,
Very
do we
nice.
look at FORT and FOI in our day-to-day clinical practice? Do you evaluate, that what has been the FORT and what has been the FOI in your patients? And when are you happy with what FORT and FOI?
See, Dr. Neeti, earlier we have to see the dose which we have given and whether the follicles are responding in that way or not, firstly, and whether there's any asynchronicity of the follicles which is going on. So definitely if we see the dose is all right according to because I think her AFC and AMH was very good. And she should have responded, and all these follicles on the day 7 should be around 12 or 13 basically, which they were not.
Yeah.
So basically, definitely we want to see the ratio of the oocytes retrieved for the number of follicles. We do count the number of follicles which we think we will get an oocyte from it. That we usually do, because that gives a rough idea. Yeah, my calculation was this and I got this much. So that is there. Definitely we should do this. And fourth is actually it is the ovarian sensitivity which is decreased to the stimulation, gonadotropin stimulation. That is the difference here. This is the ratio between the oocyte and the number of enteral follicles which is seen at the time before the start of stimulation. And fourth is the decreased sensitivity of the ovarian follicles to the gonadotropin. So definitely
we want at least 50%. Yeah.
Yeah.
So if we're starting with AFC of say 14, we want at least 7 oocytes at the end of the day, isn't it?
Definitely. If it is less than 50%, that means it falls in FOI. And if we see that less than 30% of the follicles have been recruited, it falls in FOI.
Yeah. So as Dr. Shalini has already mentioned, there could be when we are looking at hypo response, it could be a discrepancy between AFC and follicular development. And it could be because of ovarian resistance to gonadotropins, or it could be receptor polymorphism. And it could be because of genotypic trait, environmental contaminants, or oxidative stress, which could play a role in the hypo response. So this diagram, Dr. Surveen also showed that maybe the dose was less than what it should have been for this patient, or the genetic environmental factor, asynchronous follicular development. And when we finally take out the X, it could be the technical issues also why we get the hypo response at the end of the cycle. So right now we are in the middle of the stimulation. So Dr. Meenu, do you agree with the starting dose? We gave, as Dr. Renu Tamar agrees, that it was a good dose.
Yeah, the age of the patient was 27 years.
Yeah.
So with that, the dose was absolutely right, but the response was not good. And as Dr. Shalini and Dr. Renu has discussed, this is a hypo response, and there are many reasons for that.
So now this patient is sitting in front of you after 5 days. How do you counsel this patient?
After seeing this number of the oocytes and the pattern of the oocytes, and we find that the less than 50% of their F4 is less than 50%. So definitely the response is not good, and we have to tell our patient only the 3 oocytes are growing in a right pattern. All the oocytes didn't grow, and even the E2 levels are 125.
Yes, 125, very less.
So very less.
Will you cancel this cycle, or you will try to salvage it?
I do not like to cancel the cycle. So I will not cancel the cycle, and I will counsel her whether we can go for another IUI cycle, or we can increase the dose. We can increase the dose. We can add 75 unit of HMG. So we might see the response after 2 days.
Okay, Dr. Latika.
And also recombinant LH could be added at this time.
Recombinant.
Recombinant.
Yes, ma'am.
What will you do? Will you cancel this cycle or try to salvage it? She has 3 follicles growing out of the cohort of 14. Yeah, right?
So, ma'am, we get very poor patients. I would prefer to salvage the cycle maybe by adding recombinant LH, at least trying there.
Okay. So how do you salvage the cycle?
So we have options are there. We increase the dose of our recombinant FSH. Along with that, we can either add HMG.
Okay. Okay. So the first step taken by most of us, because we feel that we have started with a less dose, is to increase the dose of gonadotropin in the middle of the cycle, or to start higher dose of gonadotropin. However, there's still no defined highest dose. This is what we were talking about in our previous lectures, that the sky is the limit, when people start giving gonadotropins, and we have seen prescriptions with 900 unit of gonadotropins per day also coming to us with the history of, taken that high doses. So we have to understand that the follicles which are there will only grow. 300 unit is enough. There will be no extra response which will be seen after 300 unit. And this lady is already getting 225 unit of, FSH. So adding LH to salvage the cycle in hyporesponse data from many robust study indicate that in slow responders, adding LH from day 7 might be more efficient than increasing the dose of FSH. No significant association found between the serum LH levels and response to LH supplementation. More plausible hypothesis would be related to genetically determined characteristic of LH and its receptors. And we know that LH is now available as recombinant LH, HMG, which is a HCG driven LH activity, and Pergoveris, which is a fixed dose combination of LH and FSH in 2:1 this thing. And we have to see, there will be a lot of evidence. There is evidence in support of recombinant LH over HMG. There is evidence which says that both HMG and the recombinant, they work well. So we basically have to see from our own clinical practice what is working more for our patient. Plus, as we showed that triad, we have to take the patient values also in mind when we are, doing this change. So Dr. Renu, in your setup, what will you do?
In my setup, I'm not using recombinant LH. We don't have, patients can't afford. It's very clear. I'm using HMG. I'm using HMG and it is working.
We have to look at the patient's pocket.
Yeah. So I'm adding HMG. 75 HMG I'm using. 225 for this patient. I might, just because she's young and I can see many follicles, I don't want her to go into OHS as well. So maybe in this patient, I will be adding 75, but that will make her FSH just 300. And maybe some amount of LH, which I increase simultaneously, step by step, seeing on again her on day 2 as well. So that is how I will go about for this patient.
And Shalini, what will you do in max?
Yeah, I will add LH. I will add recombinant LH because I'm in the private sector. So the patients are usually affording patients.
Oh, yeah.
Having said that, it doesn't mean that we don't get that class of patients. So as already everybody is saying that we have to see the patient's pocket. I agree with Dr. Renu. If the patient says he can't afford, then HMG. It's just the cost.
So somewhere deep inside, we all know that recombinant will fare better, but we go on to HMG only when, cost is the factor, isn't it?
Yeah.
Or any other panelists think some other way? Please come in. Any other panelists who think some
No,
other
I
way?
think cost factor is the one thing which obviously even I never used recombinant LH since I'm in Hyderabad since the last 7-8 years. Before that, in Chandigarh we used to give recombinant LH. Here I have not used. So I think that is the one thing. And availability, if you want some for 1 or 2 people patient, you want to keep those injections here, that is not cost effective for me too. So I don't normally I add maybe normal HMGs.
But there's a perspective to it.
I can add one thing.
But
we may cancel the cycle also. In my view,
we can
cancel the cycle also.
Maybe.
From next cycle, we can do fresh start. Because
before cancelling, I would give.
Recombinant is given.
Can I comment?
Yeah.
Even normally we should not go and give this, that we should not cancel. Patient has already spent some money on that. We can still receive the cycle.
Yeah.
So that
patient should be converted. Yeah, even I would feel, and I would agree with Dr. Renu, that patients should be given a trial of another 2 to 3 days with either HMG or LH, because she is already, and we've started the cycle with recombinant FSH. Recombinant FSH is a costly gonadotropin, and we cannot let that the entire cost go waste, which she has already spent. So I guess I would certainly like to give another trial of 2 to 3 days before we take this decision.
And even I want to add one thing here, Neeti, just I'm sorry to interrupt. For this recombinant, I think if the patient had been elderly, maybe that would have been a better option. She's young, patient can work for her. For that thing, if she's elderly and then you have to decide whether you have to go give a recombinant or a HMG, then maybe recombinant would have been better for that patient,
So you're right, Dr. Renu. This patient also had cost constraint. This is a true patient which we are discussing. So we converted her stimulation to HMG 300 units. An antagonist was added after 1 day because till day five, there of stimulation, the response was still low. So we added antagonist after 1 day, and the stimulation lasted for another 6 days. And this is what we got at the end of the day. HCG trigger was given, and 6 oocytes were retrieved after 36 hours. 2 day 3 fresh embryos were transferred, and beta HCG for test for this patient was positive. So ultimately, her FOI was still less. Out of 14, if you see 6 oocytes were retrieved, but at least her cycle was salvaged, and good for her. She got 2 day 3 embryos, and because maybe she was young, she could conceive in the first go only. So, Dr. Akriti, if she needs another cycle now, suppose she was not positive, or maybe like what Doctor Ritu was suggesting, that suppose you decided to cancel the cycle or the patient is not ready to go ahead, what modification will you make in another cycle?
So first of all, if in case we cancel it, or if in case we do it and the rescue does not work for the next cycle, probably the first thing which is for sure is that we have to start. We can start at a higher dose, as it could be because of the FSH sensitivity also. The sensitivity of the follicles could be low if the response has not been good as such. Or the second thing is, after 3 days of stimulation I would add the LH in the start only. I will be adding it in the start. Like suppose I'll be starting with the total dose of 300, and I'll be trying to add the HMG, because here also the cost factor comes. We are not using recombinant LH. So I'll be adding, the total dose should be 300. For me, the start dose would increase. Secondly, I would add the HMG in the beginning itself. So because there has been a poor response, so adding an LH also would, and after 3 days, I will assess the response.
Dr. Leena?
Yeah, I agree.
Will you change her protocol? Dr. Leena, will you change her protocol? She went for an antagonist protocol in the first go, and she did not make a good cohort.
Yeah, but I'll prefer antagonist protocol only. The results are similar, although the literature says that you can try long protocol also, because it will give you a synchronous cohort of follicles, which was absent initially in this case. Otherwise, you can do a luteal phase priming also. You can try with estradiol to get a synchronous cohort. Along with that, you do the dosage modification. Like we can start with 150 IU HMG plus 150 recombinant FSH, along with the antagonist cycle.
Dr. Latika?
Yes, ma'am.
What would you like to do in the next cycle for her?
Ma'am, in the next cycle, as already said, a priming can be done either with estrogen 2 milligram BD for 7 days before we start the protocol. We could also try the microdose flare in poor responders, and then
hello,
HMG right from the beginning.
Excuse me, I just wanted to know, it could be because of the inhibitory action of the FSH receptor. So in that case, it's better to use HMG instead of using FSH plus HMG. 2:1 ratio we can find in HMG. So we can use HMG instead of using.
Actually, HMG is 1:1. So what I think Dr. Leena is trying to do is to make it 2:1, right?
Okay.
So
Right.
Because HMG is 1:1, so she's saying 150 unit of FSH and 150 unit of HMG.
That will be better option.
Yeah. So Dr. Shalini, what will you like to do in this patient next cycle?
Yeah, Niti, I would even prefer HMG in this case, or maybe the combination of FSH and LH, maybe like the 255 of FSH and plus 75 of LH, or 300 HMG I would like to use in this patient. Agonist protocol, I would not like to use in this patient because AMH was high. Maybe the hyporesponder was hyporesponder. That could be because of the polymorphism, oxidative stress, environmental factors, whatever it may be. But the log agonist protocol, because the AMH was high, I guess it was 3.1, and with AFC of 14 or 16. So in that case, I would not prefer a long protocol, because she might land up in OHSS.
Okay, another view. So I think all of the panelists are agreeing to this, that we will go ahead with antagonist protocol only. So for synchronization of cohort, maybe we can use some pre-treatment, as
Yes.
mentioned, but we will go for antagonist protocol only. So
Ma'am,
effect of dose.
Preeti ma'am,
Yeah.
I have a question here. Like you said, for synchronization of the cycle. So the cycle cohort to synchronize the growth. I mean, there are studies which ASHRAE, there are guidelines from ASHRAE only on the stimulation protocol, which say that pre-stimulation with either in antagonist cycle, if you're using antag only, pre-stimulation with either estrogen plus progesterone or even progesterone alone, or even with contraceptive pills is not going to add to the improve the potency or the efficacy of the cycle. So there is a ASHRAE guidelines, which is on ovarian stimulation in 2020. So ma'am, what do you think on that? Like, have you observed in clinical practice, like it helps?
When when you find that the cohort is not coming out good, right? Because one thing is that maybe the dose which we started was less. Definitely we have to change the dose, no doubt about that. We have to change the dose, and we have to consider adding LH, either HMG or recombinant. But we have to keep in mind that somewhere the cohort was also not good. Whenever you, out of 14 follicles, if only 3 grow, the cohort development is not good. So for that, one can consider giving some pre-treatment like estrogen pre-treatment, which she talked about, or even OC pills. So for OC pills, contradictory studies have also come, but one would think of synchronizing the cohort also in the next cycle. Yes, Dr.
Preeti,
Yes,
can I just say one thing?
I can add one thing. We can use for a synchronous cohort. A long protocol is also good.
Yeah, that's true.
Long protocol gives a very synchronous cohort in my clinical practice I have seen. But I'm not sure that
I second that.
is more synchronous, gives a more synchronous, and it helps in the increased FSH activity in the previous luteal cycle, because of which it gave a asynchronous cohort. It can control that also in a long protocol. You can consider long protocol HMG in this patient also.
Absolutely.
Even I second that. Even I used to do that, especially when we have a IVF cases in batches. We don't have 24/7
Is
embryologists.
my voice visible? My internet connection is okay.
I think everybody's
Voice
internet connection is bad today.
Dr. Neeti, you're having a voice echo.
It's
Here
raining
in
here.
Uttarakhand, I think we have a very bad connection today.
Maybe some
Rains here.
doing us webinar on a very stormy day, probably.
It's good, but I think it's good.
So this study shows that according to a dose increment of recombinant FSH remained the only significant predictor of number of oocyte retrieved in the subsequent IVF cycle. But adding recombinant LH for suboptimal responders also, there is another study which says that women with a hyporesponse to exogenous gonadotropin might benefit from LH supplementation. However, more trials are required. This is 2019. I think we discussed this in chat box also. There was one question on this. Would you consider FSH receptor, LH-CGR receptor polymorphism testing? I think this is a very expensive test, not widely available. So it is not necessary to do this test to actually, about adding LH. There is clinical relevance maybe in future if, it becomes cheaper. Then like for a response to predict a response, we are doing AMH, right? AMH and AFC. So if these tests become cheaper, maybe in future we will, along with AMH and AFC, we will also get a genetic variant, variation check. But not as per now, these tests are not widely available, expensive, so we are not doing it. Now we come to case number 2, Dr. Nymphia.
Okay. Mrs. SV, she is a 29-year-old girl presenting with infertility of 4 years. She had 2 cycles of ovarian stimulation with clomiphene and IUI in the past. Her BMI is 23, AMH of 1.1 with an AFC of 4. Semen parameters are also compromised, 5 million with 35% progressive motile sperms and 1% normal morphology. She was taken up for an IVF. On day 3, 300 units of recombinant FSH was started in an antagonist cycle. Trigger was given on day 11. 3 M2 oocytes were retrieved. 1 grade A and 1 grade B embryos were transferred on day 3. Beta HCG was negative. So what protocol should be used in the next cycle? And it should be long protocol or an antagonist? Dr. Renu.
Hi, Nitya. Thank you so much. I think so. The protocol, the dose was fine for this patient. And you said OFCs was only 4. She falls in this Poseidon group 3, according to me. And the dose was 300. That was, and if we got 3 from 4 AFCs, we got 3 empty oocyte. I think that was fair enough. There's nothing wrong in that. And even you could use long agonist protocol. There's no problem. The results are similar for both.
Yeah, as far as these protocols are concerned, Dr. Shweta had covered these. So there are several advantages and disadvantages to both the protocols. Long protocol is supposed to give us a better synchronous cohort and a better luteal phase. And disadvantages being, of course, longer stimulation and a higher dose overall requirement of gonadotropin goes up. And in an antagonist protocol, the disadvantage is being more of asynchronous follicles, and advantages are that lesser number of gonadotropins are needed. Next slide. We've done this. So she had showed few studies which showed that there is no difference in long and short and antagonist protocol. But there was one study by Sunkara which had showed that there was not significant but a slightly higher number of oocyte cohort which was achieved in a longer this agonist protocol. Now this is again a retrospective study of antagonist versus long protocol for patients with a decreased ovarian reserve. A total of 1,233 patients were recruited, and they showed that there was an advantage of agonist protocol in Poseidon group 3 patients, and with no advantage in Poseidon group 4. The agonist protocol was associated with lower ET cancellation, higher implantation rates, and higher live birth rates. An embryo euploid rate or endometrial receptivity might also explain this difference. Next slide. Now, the type of gonadotropins. Will you now consider starting an LH supplementation from the beginning, Dr. Leena?
Yeah, Dr. Nymphia, I think initially she had received HMG. Just can you go back and
300, no FSH. Just FSH.
Okay, she had received only recombinant FSH 300. Definitely, I would like to start with HMG 300 in this case from beginning. So as we have learned that LH supplementation helps in such cases in poor responders.
Yeah, so I had a point to say, because we've been talking about the cost of a recombinant LH in the last case. So if, as now we know, if we know the Poseidon, and we now know that if we can diagnose and put a patient into a particular category Poseidon, and we know that the LH has to be given. So the cost of a patient is going to spend a particular amount of cost. And if the whole cost is wasted versus adding a few days of recombinant LH. So I don't think, sometimes it's the inhibition is in our mind that it's costly. It was in our mind also before we started, and we get all categories of patients. It's not that every patient which we get is affluent and they don't mind spending money. But sometimes when we counsel that this is the cost involved, but if you're adding a injection which has a slightly higher cost for maybe initial few days for recruitment, then sometimes the patient versus the whole package, if they are adding certain amount of cost to the cycle, if you counsel might not mind. So
versus don't mind getting good result.
Against getting good result.
I agree with Dr. Nymphia here, because in our clinical practice also, we have found that when we give recombinant LH, we are more confident. And we get better outcomes. There is no doubt about it.
This was in our minds also. Yes.
When we are giving HMG, it is only for the cost in mind. Yes. Nothing else. If you look at otherwise, if you think about the response, definitely we get a better response with recombinant LH.
Yes. So in this particular patient, we did an embryo pooling. We counseled her. We did a dual stim with recombinant LH and FSH of 300 and added LH of 150. In follicular phase, we got 2 grade A and 1 grade B day 3 embryo, and luteal phase 3 grade A embryos. 2 blastocysts were transferred in the next cycle, and a beta HCG was positive. So experience with dual stimulation, Dr. Shalini.
Yeah, Nymphia, my experience with dual stimulation is very good, especially in the poor responders, type 4 especially, I mean Poseidon group 4. And the second, obviously, the concept is that there is a multiple wave recruitment of follicles. So somehow even I have found that where I have got only 1 or 2 good embryos in the follicular phase, I have gone up to 3 or 4 embryos in the luteal phase. The only drawback is that we cannot do the embryo transfer in the same cycle. The embryo pooling has to be done, or maybe even if the luteal phase also gives a good embryo, then alone the luteal phase embryos can be used. So overall, my experience with the luteal phase stimulation is very good. I mean, I find more embryos formed with good quality in luteal phase as compared to the follicular phase.
Dr. Meenu, you want to add something?
Yes, I have also started trying the dual stimulation protocol for last 3 months only, and I'm finding the better result. And we have also seen in the luteal phase the number of the oocytes we received is more than in the follicular phase. And we have seen when we do the TVS on the second day, we see only 2 follicles in each ovary, and we start stimulating. And end of the this thing ovum pickup, we find that during the last days of the stimulation, the small follicles are coming in. They are around 10 to 12 mm of size, and when we do dual stimulation in the luteal phase, they pick up and we get good number of oocytes, and we have found good number of M2 oocytes and good number of blastocysts and better clinical pregnancy rate.
Yeah, just one point. The only thing is that you need to be patient because it takes little longer. You have to consult the patient regarding the high dose in the luteal phase. And like maybe after 4, 5 or 6 days, you start seeing those very small follicles which start coming up.
Dr. Leena?
One question. There's
Yes.
a question from my side for duals, because I've not started. Didn't have the courage to start dual stimulation. Only thing, because I'm doing in batches, obviously, so I have to call my embryology team again in 15 days. Maybe that is the reason. But do you think, I mean, if this cost of the obviously laboratory becomes double, isn't it? And the injections will be doubled. So it's the double cost you charge from the patient, or maybe 1/3 extra, or what?
Dr.
It has to be double cost.
Yeah. So, Dr. Aditi, Dr. Aditi,
Yeah.
actually, when you start something, you have to kind of, and you are trying something on the patient, you have to kind of make a package and you make the cost reduced. So what we have done is that when we are doing the second pickup, we are charging 30,000 less than what we do in the follicular phase.
Okay.
Right, just to encourage patients to take a duostim because you are trying a new protocol, right? But what we do, the counseling of the patient in duostim is very important. See, we have done duostim for last 2 years, and we have found that in around 50 to 60% of the patients, the number of eggs and the number of embryos will be better in the luteal phase. Okay, in around 30%, they might be the same, and in 20%, they will be less also. So you have to tell the patient that there is no guarantee, right? That in luteal phase you will have a more number. But another thing which we found is that even if the number of eggs retrieved are less in the luteal phase, say 5 eggs in follicular, 3 eggs in luteal, still the embryo conversion and the quality of embryo might be better in luteal. So all this counseling is required. You can't tell the patient that it's a very rosy picture, you will get better eggs, better embryo. No, it doesn't work like that for everyone. This counseling is required. But in our experience, 50% to 60% of the patients will benefit. And
so Dr. Neeti, can I add something here, Neeti?
Yeah.
Hi, Neeti. I just wanted to clarify this also. There's some confusion in this. I do agree with whatever points you said. If the patient is having very low reserve and you have got already 3 M2 sites, but then you have to see after the pickup whether the ovary really has any AFC or not. But if they're really dormant kind of ovaries, definitely you will not go for this dual stimulation. It is only if the ovary is having some AFCs, and then you have a chance that you may recover. If the ovaries look very dormant, I don't think so we will be able to do a dual stim in that. So that point is also to be very clear.
You're right.
To be considered, yeah.
Maybe, when we started doing duostem, we never took care of this, because sometimes antral follicles are so small in a stimulated ovary after aspiration, not always possible to, ascertain how many antral follicles are left. But yes, now we are doing this, what you are saying, that it is not that when antral follicles are not there, we are not doing duostem. We are still doing. Sometimes the follicles come up, which we have not seen, but we are making a note of how many antral follicles we are seeing at the end of the retrieval after the follicle. We are doing
and Dr. Neeti, are you using medroxyprogesterone acetate throughout, or you're using?
We are using medroxyprogesterone acetate in the second phase, Dr. Leena. The idea was, because it was a new protocol and we are in a private sector, we cannot put our patients to experiments, So what we did is that, we started with antagonist protocol, and we gave, otherwise, after follicular phase, it is preferred to give a GRH agonist trigger, so that you can have an early luteolysis and early recruitment of follicle. But we used to give dual trigger also, or HCG trigger also, because many a times patients will not want. They might not want to go ahead and suppose they are good embryos, they want a fresh transfer also. So we always kept the option of fresh transfer open. And that's why we gave GRH agonist, trigger in a GRH antagonist cycle, the follicular phase. But in the luteal phase, once we decided that, okay, we are going ahead with a, luteal stimulation, then we did this, that we added medroxyprogesterone acetate. Because now we know that we are not going to do a transfer. Medroxyprogesterone acetate helps to, keep the LH under control, and it also does not let the period come, the menses start. So it works wonderfully. None of the patients, even after, actually the cycles, because Dr. Shalini also mentioned the luteal phase is longer. So the period, the entire period may be 35-40 days, but the period will not come. The menses will not start.
That's a good suggestion.
May I add one point to Aditi, what she said? Now coming to the cost, like Neeti said that they have reduced the cost to 30,000. Aditi, because see, the first cycle, if you're charging the patient, the first cycle includes your ovum pickup as well as the embryo transfer. Now, when you're doing the dual stimulation, the second cycle, we are just charging only for the oocyte retrieval, because the embryo, the amount or the payment for the embryo transfer is already taken. Now that's up to you and your center that how much you want to keep the cost as. And moreover, these days patients, they do want their own genetic material only. They are not ready for the donor cycles. So I guess it's worth a trial, and the cost can be worked on at your own center.
And also medroxyprogesterone acetate is cheaper.
Neeti ma'am, I have a question for the panelists, like here only. Like I've seen in my practice, I haven't used dual stim till now. Although I have, after this lecture, probably I will start. Taken that much of confidence from you all for sure. Ma'am, like suppose if a patient of poor responder itself, like if we see on the third day, since I'm not planning for a dual stim, I call her on the day 3 post the pickup and she's not for a fresh transfer. Right. Sometimes I see follicles like which are like previously they were like 6 or 7 or 8 because that was a new wave which has come up, and now they have reached 12, 11 or 13. At that point of time, do you think I should add gonadotropins and motivate that patient for the pickup in this luteal phase?
Definitely you can do that, Aditi, but the only problem is that if the follicle is already like 14 or above, this one follicle might just go ahead of others, because luteal stimulation takes longer, right? One more thing, which what we do in luteal phase is, like in follicular phase, you call the patient after 5 days. In luteal phase, we don't call after 5 days. We call after 8 days only, because we never expect, because the luteolysis has to happen and then the new follicular cohort has to grow. So it will never be that fast. So we call after 8 days.
So ma'am, these follicles which we see in the luteal phase post the pickup, suppose there have been like 8 follicles, they all were retrieved. They were all 12 above. But after the third day of pickup, if I call her just for a scan to see her luteolysis and all, then I sometimes, in
You
some
can
patients, I
start.
see
You can
certain
start.
follicles.
You can start because if you are saying that you have picked up all the follicle, what
Yeah, I did.
was also
They could be
discussed.
corpus luteal cysts
So
also.
12
No,
to
they were
14
not cysts. I mean, ma'am, they were size was, no, ma'am, because corpus luteum is something which we can visualize. So they
Yeah.
actually look like follicles. So they're not corpus luteal cysts.
Start,
They are follicles only.
If you are confident that you have, taken out all the oocytes in the follicle, all the follicles you have aspirated in the follicular phase, then you can start. Definitely.
Dr. Neeti, calling after 8 days, what is the advantage in that particular?
The advantage is see, we are trying to do cost cutting here also. These patients do not require antagonist, right? So that cost is also reduced. The tests cost is also reduced. You know that LH is not going to surge. It never surges. It never surges. Okay, so LH is not going to surge, and you do not expect any. No patient will be ready before 8 days.
So when are you starting medroxyprogesterone acetate in the next phase?
After from the
Retrieval.
third day only, from the time when we are starting the gonadotropin.
Okay, that is after 8 days. Are you putting?
No. After 2 days, we are starting the gonadotropins after 2 days. No, from the third day of retrieval.
Okay.
After 48 hours, we are starting the medroxyprogesterone and the gonadotropin together. Right?
There are various protocols. I think the medroxyprogesterone can be started the day after, or even there are studies which are showing that you can start the medroxyprogesterone right after the oocyte retrieval.
Different
there are varied protocols. Yeah.
Yeah, it is still in
But
the learning phase, so everyone has to devise their own ways, right?
Yeah.
Dr. Aditi, you have to realize that overall your consumable cost with lesser number of price also goes down. So you can build package, you can talk to the embryologist that the overall exceed the time, everything goes down. So maybe you can just work around it and start it.
What is
so what is
surprising is, that patients are not, complaining. We thought that when we started duostem that they will be complaining about going through so many injections in one cycle.
Exactly.
We have patients who have done embryo pooling in, 2
Dr.
duostem
Neeti,
cycles.
yes.
By
Dr.
hook or crook, they
actually,
want their own
initially-
eggs.
Yes, initially till the time we haven't
What the
made a
best thing.
package, it was bothering the patient, the cost part. Once we had made a package, every patient I counsel every embryo pooling. It's never.
Yeah.
And patients, they are well read. They read it on the net like the day I'm going to start.
They come and ask for it sometimes.
Yeah, they do read it. I think, and because the main motive is to just get their own eggs. That is what it drives them to go with the, luteal phase.
So what is luteal phase priming? Would you consider it in this patient, Dr. Akriti?
Ma'am, luteal phase priming, yeah. For patient, like ma'am said, already discussed how for this patient, we can do that with estrogen and progesterone combination just to synchronize the cohort. That's it for a poor responder.
And what would you use for that?
Ma'am, estrogen and progesterone. So I'll be using estrogen, the micronized progesterone. I'll be using micronized, this one, what you call estrobet tablet, 2 milligram twice a day. And that would be given for 6 days to 7 days, and adding the progesterone in the form of either norethistérone, 5 milligram 3 times a day.
And what about OC pills?
I usually don't prefer oral contraceptive pills because many times it is seen that after using oral contraceptive pills for like variation of 12 to 18 days, probably, which many people use, there's an increased demand for the gonadotropins.
Yes. So Dr. Shweta also mentioned in her slides that a very prolonged usage of any kind of pretreatment might lead to a lot of ovarian suppression. Next slide, Dr. Neeti. Okay, so this is meta-analysis for cycle cancellation in pregnancy after luteal estradiol priming in women of poor responders. It is a meta-analysis of 2249 publications. Women exposed to estrogen priming had a lower risk of cycle cancellation and improved chance of clinical pregnancy. There was no significant improvement in the number of mature oocytes obtained or number of zygotes obtained per cycle. Next slide. Dr. Shalini, any comment on progesterone prime stimulation for poor responders?
I had tried it in few donors, But somehow, I don't know, my experience is not very good. My experience is that the LH level rises. So again, I've gone back to the antagonist cycles only. So I am not using much of this progesterone prime ovarian stimulation.
Okay, so this was
Shalini,
specific.
what is the dose you were using?
10 milligram hydroxyprogesterone. I was using it OD. Right from the, I mean, the start of the, I mean, not from the start, but maybe like the 4th or the 5th day, you know.
So, okay, I was specifically talking about poor ovarian responders, but if looking at donor cycles or if we talk about polycystic ovarian patients, our experience with progesterone prime stimulation has been excellent. So we just check the LH levels.
Please share your experience. Even I don't have good experience with this hydroxyprogesterone acetate.
So
please.
if I'm giving progesterone to 10 patients, probably one might have a surge and I might need to add an antag maybe for last just 1 or 2 days. So the injection cost and the prick cost, basically it's most of the times adding 3 or 4 doses of antag won't add much cost to the patient.
Yeah.
But patients start saying, you'll add another injection today. You said it will be 10 days of injection. There's another prick today. I think that bothers patient more than the cost. So our experiences has generally been good. Dr. Neeti, what about you?
Not much. We have done PPOS except for the duostem luteal phase. We haven't done PPOS much, so can't say.
Not
even maybe the 1 or 2 patient Nymphia, which you got it later, I got it early. So I didn't have the courage, you know,
maybe.
to go ahead.
Maybe.
Yeah. And honestly, can I just ask one question? We all talk about the ovarian suppression after giving the birth control pills, but is everybody not using? Maybe like I use it for 15 days and I don't find so much of suppression.
Yeah, I do that. Even I do that.
Yeah.
And for a good cohort, you know, because
I mean, whatever the literature may say, I mean, it might be right, but my personal experience is that giving the, you find really a good cohort by giving, you know, in the pre-treatment, the OC pills. Maybe you give it for 15 or 16 days.
Especially in advanced stage, poor reserve, where the
asynchronous,
asynchronous follicular development is there, premature recruitment of follicles happen, and on day 2 only you see a 13-14 mm follicle, you know, then it's always better to. Okay, Dr. Nymphia, you can go ahead.
So this is just a systematic review of various kind of OC pills, progesterone, estrogen pre-treatment for ovarian stimulation for women undergoing ART. So they said antag protocols, COC pre-treatment was associated with a lower rate of live birth rate or ongoing pregnancy than no pre-treatment. There was insufficient evidence to determine whether rates of live birth or ongoing pregnancy were influenced. Progesterone pre-treatment may reduce the risk of ovarian cysts in agonist cycle, and COC in antagonist cycle may reduce the risk of pregnancy loss compared with no pre-treatment. Next.
Now we'll have to go fast. Case 3.
Yes, quickly.
So, Mrs. NK, now we are going to
Poseidon. Wind up after case 3, I guess. It is already
Poseidon 2.
Yes.
Mrs. NK, 38-year-old lady, presented with secondary infertility for 2 years. She has regular cycles and she has one child 8 years back, normal delivery. And after that, she was using barrier contraceptive and she then started trying for the second child. Her BMI is 22. Her AMH is 2.3 nanogram per ml and AFC is 12. And husband semen analysis, when it was done, it was found to be only 2 to 3 motile sperm per high power field. So she was left with no choice but to go for IVF. So, Dr. Renu, how many oocytes do you expect to retrieve in this patient? 38-year-old, good reserve, AFC 12.
Hi, Neeti. I think so. The patient, though age is the factor over here, maybe the aneuploidy rate could be there in this patient, but with the FC of 12 and AMH of 2.3, I think so. We should get around 6 to 8. Yeah. My expectation is this.
So the couple was taken up for IVF with ICSI in antagonist cycle. On day 2 of cycle, recombinant FSH 225 unit was started. So this is also a true case, and this is our standard dose, right? So if a patient has good reserve, we start with 225 unit. So 225 unit recombinant FSH was started, and as you can see, the cohort in the end. So out of so many follicles have grown up. Dr. Meenu, what do you think about the response so far?
The response is not bad. Response is quite good with recombinant FSH. In 38 years of with a good AMH, the response is quite good in that patient.
Yeah, so we are
So,
seeing 8 follicles which are like more than 14 mm. So the response looks like good in this patient. So recombinant HCG trigger was given and OCR was planned 36 hours later, but on the day of OCR only 4 eggs were retrieved, out of which only 2 were M2 on which the ICSI was done, and one day 3 average grade embryo which was transferred in a fresh cycle and it failed. So total flop this cycle became. So out of 8 follicles, 4 eggs, 1 day 3 average embryo and failed cycle. So Dr. Akriti, what do you think would have gone wrong in this patient?
For me, I think the trigger, I would be adding a dual trigger for this patient in the next cycle, and also maybe a delayed approach for pickup. Sometimes there's a delayed maturity of follicles. Sometimes even because of the delayed maturity of follicles, we might get less number of oocytes. So there can be these 2 reasons. So adding an agonist also will be helping, and also delaying the pickup.
Delaying
so
the pickup,
I would be.
We have see the size of the follicles. What do you mean by delaying the pickup?
Ma'am, see, basically it means that if you have heard about double and delayed stimulation, wherein we can give the agonist and the HCG trigger together, but the duration is a little bit more. So we do the pickup at 36.
You're talking
But
about
she's talking about double trigger and dual trigger.
Yeah.
Okay.
Yeah,
I thought she meant that we could have gone ahead with the stimulation. Okay.
Yeah, even I thought so.
I got your point.
That would be post mature then if we had gone so late beyond 10 days. No?
Yeah. Dr. Aditi?
No, ma'am, no. Not the length of the stimulation, but the trigger
we all
timings.
thought that.
Yeah.
We all thought that.
Got your point, Dr. Akriti. Dr. Aditi, what do you think would have gone wrong? What happened to this patient?
Look, I should not say that's a technical problem because sometimes even we feel so. Sometimes retrieval can be a little less. Being a 38 years female, we can expect less retrieval actually. Exactly. Maybe polymorphism the same. So that is what does happen. So we cannot just blame husband because he has motile sperm less, but these oocytes can be a problem. Anybody is much more obviously. So even the mature oocytes may not be there. So that may be a reason.
So many a times we find older women with very good reserve, but they do not respond very well, right? So when we talk about follicular output rate and follicle to oocyte index, FOI, or low prognosis patient, look at what they say. That there is ovarian sensitivity was highest in group 3 and it was lowest in group 2. This is the group which we are talking about, an advanced age lady with a low reserve. So the ovarian sensitivity is lowest in this group. So sometimes, even if it is showing, but you might not get oocytes out of them. Older women may have lower ovarian sensitivity due to polymorphism, low gonadotropin doses, suboptimal trigger, problems during oocyte pickup. Older women have impaired mitochondrial function, increased granulosa cell apoptosis, increased oxidative stress, minimal responsiveness of antral follicle to exogenous FSH reveals oocyte dysfunction to some extent.
Hello.
So how will you plan her next cycle, Dr. Meenu?
This patient, we have to give some pre-treatment.
Okay.
But here, what I find that in the last day of the TVS, we find a good number of the follicles. The only thing he should, because of the genetic polymorphism, which can be the reason. But we have we would have got the good number of the retrieved oocyte, because the good number of the oocyte we can see. But the only we got M2 oocytes only. There was a 4 oocytes. So next cycle, as she is 38 years of age, we can add some adjuvants, and we can give some pre-treatment with the estrogens. And protocol here we use is the antagonist protocol. I think antagonist protocol will be the best for her. And but for synchronous pool of the oocytes, it is better to use agonist protocol. As far as we see that the age is the only factor, otherwise her AMH and AFC number is quite good. So here gonadotropin we will like to shift to HMG. Recombinant FSH, equal dose of recombinant FSH and recombinant LH we can go for. and the double trigger can be the right choice for her, because in the previous case it seems that there can be some region because of the triggering defect. So we can go for the dual trigger in that patient to expect better results.
Dr. Leena?
Yeah, Dr. Neeti, we know that as the age increases, the level of androgens goes down and LH is also needed. So in this particular patient, maybe I would like to add testosterone gel in the previous cycle before starting stimulation. And regarding the protocol, I would stick to the entire protocol, but definitely recombinant LH, as Dr. Nymphia was mentioning, is a good choice to start with. Although usually till now we are using HMG only, and the final trigger will be a dual trigger.
Right. Dr. Renu, any additions to this?
Yeah, no, I will not agree with pre-treatment at all, because we got a synchronous growth of the follicles. There was no wrong in this. I only agree that we should have given a dual trigger for this patient. That's it.
And maybe LH?
Because the follicles have grown synchronously, but only maybe the trigger problem could have been there. I do agree with that.
Neeti, how much trigger was given?
I mean, HCG trigger, recombinant HCG.
See, if the follicle would have been asynchronous, definitely I would have think at this age group. But yes, if the follicles were synchronous, you could have grown the follicles at that size, around 8 follicles. Maybe there is a wrong with the trigger in this.
So the androgens were not given the synchronous growth.
No, whatever you say, even if she's 38 years, you have made that follicle. You know, pre-treatment is usually given in those patients who are having
the quality also.
AMH levels are low in those patients. See, that will help in those patients. But not if this follicles have grown. That is my call, because the follicles have grown.
This case was tricky, Dr. Leena, because we also were very surprised. She was a 38-year-old, but she had a good reserve, and her stimulation, as far as it went well, and we had 8 follicles at the end of the day with good E2.
Yeah.
But somehow the number of eggs were
one thing I can make out. Sorry, one thing we can make out that her E2 was 1200.
Yeah.
So we should expect maybe 6 eggs. So more than that,
yes.
I was not expecting with the 1200.
Like that, Doctor.
Yeah.
Obviously, it is not. Obviously, it is not. That is
in
what
antagonist
we
cycles, the E2 at times can go very low. I mean, 1200, I think it can be a normal as per the 8 oocytes they were.
I'm going. So in management of group 2 patients, attention should be given to both oocyte quantity as well as quality. Changing the protocol could be the first option, depending upon your clinical experience. Adjustment of starting gonadotropin dose, addition of LH. This is one thing which I felt, because we once we discussed it with Dr. Nalini Mahajan also, and she said that they have a protocol that they would add LH to every woman who is more than 37 years going ahead with stimulation. We don't do it in our practice, but maybe that can help. Supplements like growth hormones, DHEA, CoQ10, other micronutrients have been used, but insufficient evidence to support it. Dual trigger, yes. Dual trigger, everybody agrees that this could have helped in this patient. And will you consider embryo pooling in her with dual stimulation? Dr. Renu, embryo pooling. Hello, Dr. Renu?
She's muted.
Achha. Dr. Renu, are you muted?
Yeah. Okay. I think we can go ahead with dual stimulation. There is no problem with this patient. Maybe pooling would help the patient because she's already 38. Then aneuploidy rates could also be there, and then with the PGTA, obviously.
And we need more number of blastocysts. We know that.
I do agree with that.
Okay, Dr. Shalini, you are already doing
it. Yeah. I certainly in favor of dual stimulation. I have started using it in patients, and I find good response, and especially when we are pooling.
Yeah. So group 2 of Poseidon are advanced age women. Given that oocyte aneuploidy rates are higher, a higher oocyte yield is required to obtain an euploid embryo. Hence, duostim protocol can be beneficial in these advanced age women. Case 4, we can quickly do case 4, Dr. Nithya.
No.
5 minutes. 5 minutes.
We have to find out. You go to the conclusion. This is a very clear-cut Poseidon 4 who ultimately took donor oocytes after one failed
So conclusion also, and the answer also is given by Nymphia. Thanks, Nymphia.
Actually, actually, you know, the group 4 are the actually, but we are encountering so many group 4 now.
Yeah, it's kind of an epidemic.
And kind of an epidemic. Advanced age women with, you know, this thing ovarian reserve. What I feel is when we are seeing these group 4 women, the counseling at the first go is very important. At the first go only, if they are willing to go ahead with their own oocyte, you have to tell them it will take 3-4 stimulation. Never give them, you know, that one stimulation. And
just go to the earlier slide, Dr. Neeti, just a slide earlier than this. So cumulative live births for low prognosis women over 5 years or 9 FET cycles. An analysis of 17,698 patients. All low prognosis women should undergo ART treatment for 2 years or 3 FET cycles. Exhibit better outcomes when extending ART treatments for 3.5 years or 6 FET cycles, particularly in Poseidon group 3 and 4, but should consider ceasing further treatment thereafter due to lack of apparent benefit. So basically, literature says that so many cycles are needed for them to have a parallel outcome. Yeah.
Right. So with this, we come to the conclusion. For success of ART, both oocyte quantity and quality are of prime importance. Poseidon low prognosis group are a challenge that we face every day in our clinical practice. And it is the utmost desire of a couple to have their own genetic child at the end of the day. Prognostication by providing realistic chances based on scientific evidence and your practice is the first step. Individualization of treatment is the need of the hour to reduce the time to pregnancy. So with this, we end our panel. Many thanks to our esteemed panelists and
the delegates. We had good attendance today. Thank you very much.
And thank you for moderating it so well, Nymphia and Neeti. Thank you so much.
I enjoyed the panel discussion.
So every
very
you know,
interesting.
such webinar, you end up picking up 1 or 2 points for your practice, right?
Yeah.
Very practical, actually. It's actually
Yes.
these kind of patients which every one of is facing in our practice.
Yeah, every day, in and out.
Every day. Poor responders.
Thank you, Dr. Neeti and Dr. Nymphia, for
so nice
Good night,
seeing you after
everyone.
Thank you, Neeti
Yeah,
ma'am.
so that's
Thank
a
you,
great-
Nymphia ma'am.
It was a great panel and great webinar. We learned a lot.
Yeah, great.
Thank you,
And
everyone.
great inputs
Thank you,
from
Dr.
our
Ritu.
young brigade, Dr. Aditi and Dr. Akriti. Very great inputs. Thank you so much for joining.
Thank you so much, ma'am.
And Dr. Ritu Prasad, thank you for your inputs and during the panel. Dr. Ritu, are you there?
I'm not able to unmute. She's writing.
Dr. Ritu, can you unmute yourself? Achha,
No, she's writing. She's not able to unmute.
Okay. Thank you so much, the delegates. We are really
No, she's there.
Dr. Nymphia, can you give the concluding remarks and thanks?
Hello. नीचे से देती हूँ एक मिनट. Hello. Hello. Thanks a lot, Dr. Neeti, Dr. Nymphia, for this excellent panel. And thanks a lot to all panelists also. So eminent panelists.
Thank you so much for
So
the
we had an excellent webinar today, and hope more to come.
Yeah,
Thank you, Dr. Ritu. Thank you, everyone. Thank you.
You, Dr. Meenu, Dr. Aditi.
Thank you.
Dr. Akriti, Dr. Latika, Dr. Renu, Dr. Shalini.
Very, very informative webinar. We learned a lot. This is the usual problem. We are getting these days. More and more poor respondents are coming in our clinic. So very great webinar.
Thank you, ma'am.
Especially I learned this pre-treatment and tech cycle dual stim very much. And from my lecture, I learned a lot from medico-legal aspect also. I read a lot. Otherwise, I wouldn't have. So,
very
nice.
Thank you, the Mock Siloro team, for sponsoring us today. Thank you so much. And with this, we come to the end of the webinar. Thank you, Dr. Nymphia, my co-convener. Thank you so much.
Okay.